Good morning, everyone. Welcome to the day 2 of Kauery Annual Heart Summit. Today, the first session, the topic will be on coronary artery disease. I welcome the panelists, Dr. Keshav, Senior Interventional Cardiologist, Fortis Hospital, Cunningham Road, Dr. Nagraj Desai, Director, Namana Medical Center, Bangalore, and Dr. Adil Sadiq, Head and Senior Consultant, CTVS, Sacra Hospital. Please, sir.
And for the first speaker of today's session, I welcome Dr. Sanjay Bhatt, Senior Consultant, Interventional Cardiology, Aster CMI Bangalore, with nearly 2 decades of experience in transradial coronary intervention. Welcome, sir.
While doctors, hello, good morning, everybody. While Dr. Sanjay Bhatt is getting the are you ready?
Yeah.
Okay.
Let's start.
So, good morning. So my topic is CHIP PCI, does it improve outcomes? So when we talk about CHIP, it means complex high-risk percutaneous interventions, or other query from my side is whether it's an indicated PCI. So complex high-risk indicated PCI, or whether it is just a complex PCI which should have been avoided. And what are the benefits out of doing this? So what is CHIP PCI? It is a PCI in the setting of either severely impaired left ventricular function, ejection fraction less than 30%, needing LV support using intra-aortic balloon pump or Impella or any other support systems like a ECMO or a CPB. Associated anatomical high-risk factors like left main PCI, post-CABG, PCI, left main triple vessel disease, associated lesion characteristics like extreme tortuous lesions, calcifications, chronic total occlusions, large thrombus burden, severe vascular calcification requiring either rotablation or orbital atherectomy, laser atherectomy, or even cutting balloons. Associated comorbidities further add to the complications in this situation. This could be either because of chronic renal failure, either post-renal transplant, patients on dialysis, GFR less than 30, liver cirrhosis, post-CVA, active ongoing bleeding, malignancy, pulmonary diseases, immunosuppression, frailty, associated ongoing infection or sepsis, and post-op patients. So 3 clinical components play a role here. This could be either the coronary anatomy, the location of the lesion, complexity of the lesion, comorbid conditions, and concomitant cardiac disease, either structural, valvular, left ventricular function being impaired, or a decompensated heart failure. So all this overlap, and this contributes to the complexity of the lesion, and we have to take a balanced decision of whether to manage medically versus surgical management, or whether to subject the patient to a high-risk interventional procedure. So most of these patients are surgically rejected patients who are very sick, and then only an intervention can save their life. So whether this intervention will benefit them. So the chip toolkit includes the chip operator, which comprises the main operator, his other team members, and even the surgeon should also be involved. He should be proficient in handling chronic total occlusions, both antegrade and retrograde, management of dissections, and competent in doing left main bifurcations, either using single or two-stent strategies, treatment of underexpanded stents by either laser or calcific lesions. Complex procedure, invariably we are asking for complications and must be ready for it. We must be ready for emergency pericardiocentesis, prompt management of coronary perforation by either covered stent, coils, embolization with thrombin, and also be competent to retrieve dislodged stents or any foreign bodies by using snares. And vascular imaging is an important component in doing these cases, either by IVUS or OCT. So hemodynamic support is very much important in these patients because of the comorbids and ventricular dysfunction, and indispensable part of the treatment protocol. We can either use LV support by IABP, ECMO, or CPB. A major advance in this is the use of the impella, which is widely adopted for protected PCI procedures. It prevents a procedural drop in arterial pressures and reduces major cardiovascular and cerebrovascular events, and entails fewer hospital days and readmission. Protected PCI with impella has made the complete revascularization of challenging anatomy much more accessible and safe. And we must be well trained to do the procedure by transradial, as many times the femoral artery may be used for either the ECMO or CPB. And also must be ready for alternative access sites like transaxillary or transcaval approaches. So there are not much clinical trials, only registry data are there on chip. There are chip registries like the EPIC Sierra study, and there is a multi-center retrospective PACO PCI registry and a single center chip registry on high-risk patients. There are two ongoing trials, the chip BCIS3 and the IVUS chip. Well, these are mainly on intravascular imaging and LV support. The independent predictors of outcomes are prior myocardial infarction, low LV ejection fraction, chronic kidney disease, left main PCI, non-radial access site, uncontrolled diabetes, anemia, and severe calcification. And this affects the outcome of PCI, which may be either in-hospital death, periprocedural stroke, or myocardial infarction. So CHIP PCI involves patient factors, complicated heart disease, and complex PCI. So as I already told, frailty, active malignancy, immunosuppressive drug use, pulmonary disease, liver cirrhosis, hemodialysis, and past cerebral infarction. Complicated heart disease like unstable hemodynamics, low ejection fraction, associated valvular heart disease, and complexity of the PCI, either CTO, left main PCI, associated use of rotational atherectomy, orbital atherectomy, and multivessel PCI. And major factors that contribute in this city are frailty, unstable hemodynamics, and use of immunosuppressive drugs, which will add to risk of sepsis. So CHIP PCI has a very high in-hospital major complication rate of up to 15% as per the registry data. Whereas non-CHIP PCI, the in-hospital bad outcomes are around 5%. To summarize, the number of those in high-risk population is large and only expected to increase in the coming years. The overall prevalence of CAD is projected to increase by 47% over the next 25 years, given an aging population and the simultaneous growth of other chronic conditions and comorbidities, which likely lead to expansion of the high-risk PCI population. CHIP PCI plays a crucial role in the management of patients with advanced CAD who will be candidates for no other revascularization strategies. So our aim is to provide symptom relief, improve quality of life, and reduce the risk of adverse cardiovascular events in this high-risk population. So given these realities, treatment of this population has been of increasing importance and plays an important role in our contemporary practice. Thank you.
I think excellent talk. I think still syntax score is the simplest way to, if the score is more than 32, the coronary practice. You told correctly about the patient factors. and otherwise, the most important thing is the team, I think. If you have a proper team, well equipped to carry that, I think that will take care of the most of these things. If the center is doing persistently well, all the complex PCA, it will become a order of the day to do a complex PCA routine. But as you said, anticipating the problem, having a good team and assistants and including the surgical vascular team is very, very important to reduce the complication in a chip piece. Any other questions?
This chip PCI patients are majority are surgical rejects and
Maybe it's also
very high syntax score who can't be taken up for surgery.
comorbidities are the major issues where surgical event rates will be very high. So that is where nowadays everybody will write patient preference. Multi-vessel PCA is the major indication for a multi-vessel PCA. I think surgeons will agree that sometimes you end up putting 3 stents, 4 stents because patients is now try angioplasty also.
Yeah, how about doing part revascularization in chip patient? In case
Hybrid procedures.
not hybrid procedure, in case you have a LAD and diagonal along with the RCA and LCX, and is there any role for limited PCI in your opinion?
Yes, we have to do a culprit vessel PCI, then staged for the non-culprit vessels. That is the order of the day.
How do you decide about the culprit vessel then, unless the patient comes with an acute coronary syndrome?
The severity of the lesion, and you can do a vascular imaging and FFR also, that will guide you in doing culprit vessel PCI. Now even we have co-registry data now. So you have co-registration with the imaging with FFR. That will help us to decide the lesion that has to be in a single vessel with multiple lesions. Co-registry goes a long way in helping us choose the culprit lesion.
I mean, this could be applicable to the general patient. I'm specifically looking for some answers here for a patient with chip.
In these patients, you do vascular imaging and associated
Yes.
FFR, and that will help you to pick up the lesions that need to be treated.
Duration of the PCA, duration of radiation. So radiation crosses 2000 gray, okay, cutoff, and dye amount more than 3 times GFR cutoff. So once you reach that, I think you should say that, okay, I'll do this, I'll finish this. Regarding staged PCA, various trials, some people say 2 weeks, some people say 40 days. Many trials have taken, suppose you have done LAD diagonal primary PCA, circ and RCA, even if you do within 40 days, is considered as a single PCA.
Yes.
But in India, it's difficult because of the cost issues, other issues. But if you go scientifically, suppose acute MI, you do one vessel, after 2 weeks, you do the other vessel, is considered as a norm in the Western literature. But here, once the patient leaves the hospital, it becomes the cost is going to. So sometimes you do the RCA, many times you have done a POBA to RCA, stabilize, send them for surgery, because the other 2 vessels are very bad and along the CTO of LAD. So that is also possible. But doing hybrid in the same sitting is a good concept, but I think it's not practiced because of obvious reasons. What is your opinion?
I quite agree to that point. Like Dr. Sandy said, a lot of the times when patient comes with hemodynamic instability, the time to actually set them up to take them into a surgical case is quite significant. And in certain cases, we again use a scoring system to find out what's the predictive risk and mortality. And at that time, it's very essential that there is a heart team concept, the surgeon, the cardiologist, interventional cardiologist, as well as the family sit and quickly decide what is the route forward. Once, for whatever reason, we go down the chip route, then I think it's quick in, quick out, and then reassess the status and see how to go forward. I think that should be the way on. And I think once again, the very fact that I'm sitting here at this conference, also emphasizes the need for the interplay between the surgeon and a cardiologist for a successful outcome for the patient.
Thank you, Dr. Sanjay. I was guided PCI by Dr. Ganesh.
So please wait, sir. Dr. Sanjay Bhatt, sir, please.
Sorry.
I'd request the panelists to give a token of appreciation to Dr. Sanjay Bhatt, sir. I'd like to invite up on stage Dr. Ganesh Nallur Shivu, Senior Consultant, Interventional Cardiologist, Kauery Hospitals, Bangalore. Dr. Ganesh has a rich experience of over 21 years in the field of interventional cardiology. He will be speaking on IVIS guided PCI.
Thank you, Swati. Good morning, everyone, and welcome to all the panelists for this Kauery Heart Summit. So today I'll be talking about IVIS guided PCI. Dr. Sanjay was talking about CHIP PCI, so doing PCI in high-risk patients and trying to improve outcomes in these sort of situations is very important. And we are always competing with the surgeons in terms of trying to get better outcomes with the PCI. Already with, we know with single vessel disease, we do quite well, but when we have to take on multi-vessel disease and all, we have to really try and optimize the PCI outcomes. And imaging has now become very commonly used in the cath labs to try and improve the outcomes. So today I'm just going to talk about basics as to what are the main indications and how we do use the IVIS during PCI. So as I said, IVIS guided PCI in certain labs have become quite common in that in most of their PCIs, they use IVIS or OCT in terms of imaging to try and get better outcomes in terms of better stent coverage and better stent expansion also. So specific indications, if we look at, then it will be any left main PCI we should be doing imaging in cases of stent thrombosis to try and diagnose what might be the cause, whether it was an underexpanded stent or whether it was an ISR or what was the cause for the stent thrombosis. And in bifurcation stenting, especially to plan and size the vessels, and also sometimes post stenting, we may use the IVIS to try and look for the complications, especially things like edge dissection, and if we are worried that the stent is not opposed or it's underexpanded. Before the PCI, to assess the plaque morphology, as I said, again, stent sizing, both in terms of length and diameter, to assess any hazy or intermediate lesions. Sometimes, especially when we are doing PCI for an acute coronary syndrome, you might find a very tight lesion, like say in the mid LAD, but proximal LAD may be hazy. And we'll be surprised how many times that we actually see that the culprit was probably that haziness, which was thrombus in the LAD, rather than the mid lesion, which was a more stable lesion. So you'll have to end up treating both. So in all these situations, IVIS or other forms of imaging like OCT will definitely help. So in terms of how the IVIS would help us in pre-intervention, it assesses, it helps us to assess the lesion morphology in terms of calcification, thrombus, ulceration, and also fibrosis. So obviously, if the vessel is calcified, then you may want to use some form of plaque modification, like either rotational atherectomy, cutting balloons, laser, or even IVL, which is more commonly used nowadays. Presence of thrombus, again, makes it important to try and use the methods to try and reduce slow flow or no flow. Unulcerated plaque would tell us that this is a high-risk plaque and needs treatment. Then in terms of looking at the reference vessel size, lesion length, severity, and also IVIS or imaging will help us in terms of a landing zone when we have more diffuse disease as to where the stent should really stop.
So if we look at it practically, what we do in terms of the stent sizing and length, so try and look for the most normal looking sites proximally and distally within the lesion segment. Measure the lumen diameter, both proximal and distal, and then choose the diameter, maximum diameter of the distal is what we try to use to size the stent. Aggressive sizing can be done if you use the mid-wall diameter rather than the diameter from the endothelium. So again, measurement of the distance between proximal and distal points will help us determine the stent length. This can be done only when the IVS is done using a motorized pullback rather than a manual pullback. So this is an example. In the top panel, you see the proximal part of the lesion, the mid part actual lesion, and the distal part which is free of the lesion. So when we measure the internal diameter, it comes to about 3.3 millimeters proximally because there is plaque, and distally the normal looking vessel is about 3.5. So probably the proximal vessel is 3.75 to 4. So if you are going to size it in a more conservative way, you go to 3.5. And then you post stenting, you can post dilate it with a bigger balloon. Now, this is an important slide which shows that the maximum diameter achieved is only about 75% of the predicted from what the manufacturer say. So the manufacturer says that with 12 atmospheres, you get to this 3.5 diameter. But most of the times you are achieving a maximum of 75%. And in terms of the stent area, you're only achieving 60%. So this is something important for us to remember. And in terms of the high-res sizing, the stent areas that you have to get, this is something we should probably put it on our most of the cath labs. So this is the minimal area you should aim for in terms of the different stent sizes. So if you look at the complications post-stenting, how the HIVAS helps us in terms of its dissection, if there are any hazy lesions, sometimes small thrombus is there, or intramural and extramural hematoma. I'll show you some examples of these. If it's important to know the difference between an under-expanded stent and an unopposed stent, because the treatment of the two are slightly different. So this is a case where there's a minor edge dissection. If you see the lower panel, you will see that on the third image of the IVUS, you can notice the edge dissection. So you can see that there's a tear in the intima. There's only a minor edge dissection because you see it only in 2 frames. But depending on how you would notice it, even on the angiogram, you would think to cover that. But this is a more extreme case where in the left panel you see the stent and the edge. And there's a complete dissection, and this is actually the false lumen. So the true lumen has actually completely collapsed. And so you would need to definitely stent that. If you don't do that, you will end up in trouble. So this is an example of a intramural hematoma. So this is the within the media, you see the more echo-lucent region, and that's the hematoma that has occurred because of trauma with the stenting. So underexpanded stent. So what is underexpanded stent? If the stent is opposed to the wall, but it's not achieved the amount of the diameter or the area that you would expect. It is known that there's a significant increase in the area with higher inflation pressures. We all know that. So we always try to do a NC balloon inflation to high pressures. And that is because we'll try to achieve a higher minimal diameter and a higher stent area as well. So this is an example here where the stent is opposed to the wall, but it's underexpanded. So obviously we went on to do a bigger, higher inflation pressure. So you don't need a bigger balloon, but you need a higher inflation pressure in this situation. So this is a case of an unopposed stent. So here you have a huge vessel, probably this is a left main, and you notice that the stent is not touching the wall. So this is an unopposed stent as opposed to the underexpanded stent. So here what you need is a bigger balloon, not higher pressure. So bigger balloon and nominal pressures we'll be able to expand the stent and achieve the good results. So these are the probably two main things that we use IVUS for in our day-to-day practice to try and get a stent to the maximum diameter. And that's the main achievement we try with the IVUS. So I'll just show you a couple of cases, interesting cases. So this is a very young chap, 26-year-old, who came in with an anterior wall MI. And the question was whether we should stent him or not. There was a lesion in the proximal LAD, but we went on to do the IVUS, which shows, if you see, his artery looks pretty clean. This is coming from distal to proximal LAD, not much of a disease. But once we come to the proximal LAD, what we see is a big chunk of thrombus and minimal plaque. So there you go, that echolucent wall. So what you're noticing is that there is minimal plaque and most of it is thrombus. Hence, we actually treated this guy conservatively and he did quite well and recovered. So this is especially important because we get a lot of very young guys with MI, and most of these young guys with MI, it's more of a thrombotic than a plaque lesion. And if you're able to avoid a stent, it's useful. Even OCT helps in this quite a bit. So if young patients coming with MI, if you can avoid stent, it's really helpful for them. So this is a case of an ulcerated plaque. This was a similar anterior wall MI, but in a more older patient, 56-year-old with diabetes, just to demonstrate that the difference. So here you notice from the beginning itself, there is some plaque disease. And once we come to the proximal LAD, you will notice the ulcerated plaque. So again, the LAD seems to be diffusely diseased. That's one of the things we notice in IVUS. As we do more and more imaging, the vessel which look completely normal actually have more diffuse disease. So you tend to get more disease by doing IVUS than by doing just plain angiography. So as we come to the proximal part, you see the ulcerated plaque. And then you see from the sort of 9 o'clock to the 5 o'clock area, there's a lot of attenuation. So there's not much of the echogenic area being there from 3 to sort of 9 to almost 4 o'clock region. And that's a typical of an attenuated plaque. And it indicates usually it's similar to the thin cap fibroathyroma we'd call that we get in ACS patients. So I have in fact another example of an attenuated plaque. So basically when you say it's an attenuated plaque, you will normally there is attenuation of the image and the echo when there is calcium. But in an attenuated plaque, just with the plaque itself, there is attenuation and that indicates high risk. And these patients have to be stented. So again, here you see with the plaque, there's attenuation of signal in the adventitia. And that's an example of an attenuated plaque. And this was an interesting patient who had come in with angina, and his left coronary system was normal, and he had a sort of a hazy looking ostium of the right coronary artery. And we were not sure whether that lesion in the ostium was significant or not. Many a times it's difficult to assess osteal lesions, both the left main and RCA. And here it helped us to show that there was significant disease there. You can see once we get to the ostium that there's actually quite significant disease in the ostium. And we went on and did angioplasty on this gentleman. So these are few examples to show how, basic examples to show how IVUS will help us. And as I said, I think IVUS or any other form of imaging like OCT should be used more regularly to try and optimize the outcomes. Thank you.
Excellent talk. I think IVUS usage, even in the registry, is less than 5%.
Yeah.
I think once the complex PCA goes up, it should work. One other major indication is, I think, low contrast PCA.
Absolutely.
That is the ideal indication to use the IVUS. And do you think IVUS or OCT reduces mortality?
Yes, sir, there's definitely evidence that there's a
It's the
decrease in
most,
mortality and morbidity. Yeah.
important thing.
Mm.
And one area I feel, suppose you ask 2, 3 indications for use of IVUS. One is left main bifurcation or contrast-induced nephropathy. I feel left main, we have to reach to the level of what surgeons gives the result. We should be able to give a MACE rates as low as or as good as a Lima can give to LAD. So we have to use a IVUS to get the perfect result of what is described optimal measurements of left main bifurcation lesion. That's one place where IVUS or OCT definitely gives the perfect result, or trying to get a better result to get a lower MACE rates.
Absolutely, sir. I think you're right in that, especially when we're doing a left main PCI, we are competing with the surgeons. And I think I honestly feel where surgeon trumps us is the Lima. I think Lima is godsend for them. If Lima wasn't there, we would be only doing PCI.
I think
And
that's,
stents are definitely better than venous grafts, but not better than Lima.
yeah, that we should be aim for. We are able to get in a low syntax score, left main PCI. We should be able to get as good event rates at 2 years, 3 years, especially if syntax score is less than
Low, yeah.
22. We should be able to get a good result.
Yes.
Any questions from the audience? So thank you, Dr. Ganesh.
Thank you, sir.
Thank you, sir. Requesting the panelists to give a token of appreciation to our speaker. Up, we have Dr. Shrikant Shetty. Dr. Shrikant Shetty is a senior consultant and head of interventional cardiology in Sakra World Hospital, Bangalore. He is renowned for his innovative approach to complex PCIs and expertises in chip PCI.
Good morning, everybody. At the offset, I would like to thank the organizers and Dr. Deepak specifically for this invitation. So I'm going to talk about imaging guided left main bifurcation PCI. Can we match surgical outcomes in the long run? And thank you, Dr. Ganesh, for setting the stage for this particular topic. And I was worried whether the discussion was going to take away the bang from my lecture. So we all know that left main disease is associated with high mortality and morbidity. Of course, much of this data about left main associated mortality comes from a previous era where we didn't have the benefit of aggressive pharmacotherapy. Of course, things have changed a lot with the advent of the newer antiplatelet regimens and our understanding of lipid management. Nevertheless, LMCA stenosis of more than 50% has been traditionally considered as a high-risk situation. But we should interpret that in the context of the current era of pharmacotherapy. And this is because of the large area of myocardium at Jeopardy. The left main, we all know, supplies almost 70% of the myocardium. And CABG has been long considered standard of care, and for good reason, because it all started with bypass surgeries till Grunzig actually did plain balloon angioplasty for left main disease, and then PCI was considered a possibility in left main disease, but the initial enthusiasm dampened because of repeat events. However, PCI outcomes have improved over the years with the advent of innovations in stents and the newer generation of stents providing better outcomes and increasing use of imaging in optimizing outcomes and newer pharmacotherapies which have made the repeat events less common. But CABG also has improved over the years. Newer techniques, minimally invasive bypasses, use of robotics in reducing perioperative morbidity, increasing use of arterial grafts. So as much as PCI has improved, bypass also has evolved in providing less perioperative morbidity. So it's a shifting, what shall I say, framework. So PCI and bypass in this complex scenario have to be interpreted in the context of these evolutions. PCI is an attractive option because of low morbidity associated with the treatment, but CABG continues to have robust and proven long-term outcomes. So this is a nice picture summarizing the advantages and disadvantages of left main revascularization. So we will probably look at several of these points in the coming slides. When we approach a patient who by discussion or by the anatomy can be offered both PCI or CABG, a honest discussion has to happen by using a heart team approach, and we should take into consideration anatomical and clinical factors which might favor one over the other. For example, what favors bypass is low ejection fraction, concomitant other cardiac surgery indication, doubtful DAPT adherence, including high bleeding risk, or diabetes with multivessel disease, and anatomical aspects such as left main plus 3-vessel disease and combined complex anatomy not suitable for angioplasty. And angioplasty may be considered in situations where there is a clinical urgency, such as urgent revascularization, or patients who have serious comorbidities, high surgical risk and frailty, and reduced life expectancy, and certain anatomical aspects like ostial or shaft left main disease and maybe left main plus 1-vessel disease, where you can offer complete revascularization. That's the point Dr. Nagaraj Desai was alluding to. Will we be able to provide complete revascularization in a stable patient, particularly, is an important consideration. Most of the trials favor CABG, particularly in the diabetic subset. This was one trial which looked at PCI versus CABG for left main patients. The Excel trial, however, it was criticized for its methodologies in evaluating outcomes, particularly the definition of myocardial infarction. It included primarily periprocedural MI and did not define non-procedure related myocardial infarction. And it showed that in patients with visually assessed low or intermediate syntax score, a cobalt chromium EES resulted in similar rates of clinically meaningful composite outcome of death, stroke, or MI at 5 years. However, the early benefits of angioplasty in terms of reduced periprocedural risk were attenuated by a greater number of events in the PCI arm during follow-up as compared to CABG, said that the 5-year cumulative mean time free from adverse events was seen to be similar with both treatments. However, the other trial, which is also considered a more recent and contemporary trial of CABG versus angioplasty, did not reflect the same findings as the Excel trial. And in its 5-year follow-up, it showed that angioplasty remained inferior to bypass surgeries in 5-year MACE. And CABG was superior to angioplasty even in those patients with a syntax score of less than 23. Though all-cause mortality was similar for PCI and CABG, and the PCI resulted in higher rates of non-procedural myocardial infarctions and repeat revascularization. Of course, both the trials have their drawbacks and strengths. So if you have to choose between bypass and angioplasty for left main, so you consider these advantages. For PCI, there are early advantages: less invasive, fewer periprocedural complications, lower 30-day MACE, and more rapid recovery. Whereas for bypass, you have more durable long-term effects and fewer adverse events beyond 1 year, particularly with respect to repeat revascularization. And these trials, Noble and Excel, did have some impact on the PCI recommendation guidelines for LMCA disease. The European recommendations have been aggressive and in favor of angioplasty, even in the pre-Excel and Noble era, whereas the ACC-AHA had been more circumspect, and after Excel and Noble, the indication for PCI was upgraded in the ACC-AHA guidelines. But we all know that all left main lesions are not the same. There are key determinants of outcomes, particularly diabetes. But as you will see, diabetes did not seem to influence the outcomes in left main PCI involving the ostium and the midshaft. And low EF, we know the STITCH trial showed that CABG in low EF patients improved outcomes, but the more recent REVIVE trial did not show similar improvements in outcome for patients undergoing multivessel PCI with LV dysfunction and those who are asymptomatic. Therefore, CABG clearly scores in patients with low ejection fraction. Patients who have significant downstream disease or high syntax score should go for bypass surgery. Patients who have coexisting CTOs which cannot be revascularized favors bypass surgery. Location of the LMCA disease, we will look at that in greater detail. The size and extent of circumflex involvement and clinical presentation. And acute presentation favors PCI over CABG. So this is a summary of whatever I showed in the previous slide. So these are all the decision-making factors. How about the lesion site? Because that is the main point of my discussion. So this is an important anatomic characteristics, because distal left main bifurcation requires more complex procedural considerations, longer procedure, more radiation, more contrast, and current guidelines consider lesion site as a very important factor in choosing the revascularization strategy, because despite all advancements in angioplasty, we all know that circumflex ostium continues to be our Achilles heel, and very disappointing nagging repeat interventions happen because of circumflex ostium. And there had been very little data on the effect of lesion site on the treatment effect between CABG and PCI. Available long-term results show conflicting reports. However, whatever is available shows a advantage of CABG over PCI because of late catch-up or crossover in the incidence of primary outcomes or mortality, and also mainly driven by repeat revascularization. So this is one trial which I came across from Dr. Sujing Park's team. This is the main compare registry, which looked at long-term outcomes after angioplasty or bypass surgery for left main disease according to the lesion location. And this is going to be very disappointing for us interventionists. So if you look at the curves for overall cohort of patients who underwent angioplasty or bypass for ostial or left main disease, you see that with respect to all-cause death and the composite outcome of all-cause death, QA myocardial infarction and stroke, there is no difference between the PCI and the bypass surgery arm, which means for ostial or shaft disease, as in terms of mortality and reinfarction, angioplasty seems to be quite good as compared to bypass surgery. However, with respect to repeat interventions, as you can see, over time, there is a separation of the curve, and bypass surgery continues to be better than angioplasty, even for ostial or left main shaft disease when you have a long follow-up. But these are patients from the who are monitored from the bare metal stent era onwards. And if you look at the distal left main bifurcation in this trial, even with respect to all-cause mortality and the composite outcome of all-cause death, QA, myocardial infarction, and stroke, and not only with respect to target vessel revascularization, for all these three considerations, for distal left main bifurcation, bypass surgery over the long term is significantly better as compared to angioplasty. And when you look at the cohort of patients who had bare metal stents, And when you look at, when you separate them with respect to lesion location, these A, C, and E are for ostial or shaft lesions. And with bare metal stents, you see that there is no difference with respect to mortality and myocardial infarction, whereas as expected, there is an increase in the re-intervention rates. And if you look at the distal left main bifurcation, surprisingly, with the bare metal stents, there is no difference in mortality and this Q wave or stroke, Q wave myocardial infarction or all-cause death. However, there is a significant difference in the re-intervention rates. So we can probably come back to that point later on, but this is very interesting that bare metal stents did not show a difference in all-cause death, even for left main bifurcation. Whereas when you look at the cohort of patients who underwent treatment with drug-eluting stents, in ostial and shaft disease, there was no difference in mortality as well as QA myocardial infarction and stroke, but repeat revascularization rates were higher with angioplasty. And for distal left main bifurcation with drug-coated stent, there was a difference in QA myocardial infarction, death, and stroke. That means it was higher in the patients who underwent treatment with drug-coated stents. So there was a differential comparative outcome noted after PCI and CABG according to the left main coronary artery lesion site. In patients with distal left main disease, CABG showed better clinical outcomes with regard to mortality and serious compositive outcome compared with angioplasty with DES beyond 5 years. And such a time-dependent differential risk was not evident in patients with ostial and shaft left main disease, except for repeat revascularization. So role of imaging, did imaging make any difference to these differences? Repeat revascularization continues to be a challenge despite new DES. And intracoronary imaging, we all know, Dr. Ganesh showed, improves procedural objectivity. And in distal left main bifurcation disease, it helps us to choose between complex versus provisional stent techniques because provisional is always better than a complex two-stent technique. And we can try and achieve defined procedural endpoints by using post-PCI imaging. We know that you have to achieve the 5, 6, 7, 8 score for CIRC, LAD, POC, and for left main proximal to the POC. But there is limited data on, like a site-specific impact of imaging. Trials in non-left main coronary artery lesions showed that IVUS-guided PCI improves major adverse cardiac event, death, myocardial infarction, and repeat revascular stent thrombosis. The first trial, big trial to look at the impact of IVUS guidance for left main PCI was the Swedish coronary angiography and angioplasty registry. Almost about 2,468 patients where IVUS guidance was used in 25% of the patients. And it was seen that IVUS guidance was associated with larger stent diameters, frequent post-dilatation, and a higher rate of complete revascularization. And it was associated with a 37% reduction of primary composite endpoint and a 39% reduction in all-cause mortality. So which means that IVUS, as would be expected, is good to be used in left main interventions. And this was consistently associated with a 46% reduction in primary composite outcome and death. So there were other trials also which looked at the clinical impact of IVUS on left main intervention, such as the main compare, the IVUS Tronco ICP, and the SCAR, all of which showed the IVUS improved outcomes significantly. The more contemporary trial is the EBC main trial, which looked at the impact of intracoronary imaging, specifically to differentiate between whether it impacts outcomes in provisional versus dual stenting of the left main bifurcation. So what was found is that the primary outcome did not differ with intracoronary imaging versus none, surprisingly, and this for a contemporary trial. However, in patients with angiographic guidance, outcomes were worse with dual stent than provisional strategy. when intracoronary imaging was used, there was a trend towards better outcomes with dual stent than provisional strategy. So it appears as though when you do a left main stent by provisional technique, uh, imaging may not make too much difference. But if you do a distal left main bifurcation lesion treatment with a two stent technique and you use imaging, the outcomes are better than when you do provisional stenting. This is uh, 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 the finding of the EBC main trial. So what we can conclude from the uh, data that is available to us is that left main bifurcation, despite all improvements in PCI, is best treated by CABG. Contemporary trials continue to show superiority of CABG versus PCI. PCI is a good option for patients with ostial and mid-shaft disease and when done with imaging guidance. Intravascular imaging does improve outcomes in distal left main disease when treated with two-stent strategy. So that means that there will be patients who will need to be treated by PCI even for distal left main disease, particularly for clinical reasons or reasons of high surgical risk. It is very important to develop the right kind of skills in performing a complex distal left main bifurcation stent methodically and to understand the use of intravascular imaging in optimizing outcomes in these patients. Though CABG continues to be better than angioplasty for distal left main disease, there will be a lot of patients who will need PCI for distal left main bifurcation. And when we do have to do it, it's our responsibility to deliver the best outcomes by using intravascular imaging. We also need to know that patients who come to us for coronary cath, they are tending to be more older with more comorbidities. Patients who have left main disease, they will have more comorbidities than other patients. And left main disease, cerebral vascular disease is one of the strongest predictor of having left main coronary artery disease, which means that coexistence of cerebral vascular disease and left main disease becomes one of the strongest point against sending for surgery. So developing the right skills and understanding for left main coronary artery intervention continues to be important. Thank you.
Actually, Dr. Shrikant presented so well and extensively. It is mandatory that we should start the discussion with the surgeon commenting CABG as an option in a patient with left main coronary intervention when a stable patient is presented to him. What do you think about it?
Thank you so much, Dr. Desai. I think it was like I said, and the whole slide and going through all of them was a very balanced approach to what we see. And it's more like what we do in clinical practice as well. So I'm very proud to see that there's a very balanced approach to patients with left main disease, keeping the interest of the patient in mind. That's primarily. I do feel that a lot of these patients who come in for left main disease, for CABG are easily treated now, not just by a conventional stenotomy, but by more and more minimally invasive approaches. Again, using techniques just like you have like IVUS, we have different techniques using flow meters that enables us to ensure grafts. And a lot of the left mains today at our center also get minimally invasive surgery. So that decreases the morbidity, even in our effort to bring it down. But of course, there are the certain patients, just like Dr. Shrikant said, specifically who are high surgical candidates, risk candidates, patients whose situation clinically does not allow us to do surgery, who have a very short lifetime expectancy. So I think in these patients very clearly put across, there is a role for left main stenting and having that exposure in terms both of, IVUS or OCI is primary to ensure patient outcome and safety. So I think that's the balance forward onto that.
In case two stent strategy is decided for left main stenting, would you proactively offer surgery for such a patient, or what is your take on that?
As a surgeon, I always believe in something called the KISS principle, KISS, and that means keep it simple, stupid. in which means the more complex you try to do something, the more chances for, other problems to turn up. Same with surgery. If we can do a surgery by a simple area in a complex situation, we're going to get better outcomes. So yes, I think if it is a situation that it is a left main, and if we do need a dual stent strategy, we need complex interventions, and it has any of the other things that we've spoken about, definitely, I think, we'd be sitting with the cardiologist and discussing what would be the best for the patient.
This presentation is open for comments and questions. Everybody seems to kind of agree with the Dr. Shrikant and Dr. Sadhika, and thank you so much for the wonderful presentation.
Well, I thought somebody would ask why bare metal stents fared better.
I mean, I've written it down out here, and I think some part of it was even new to me as well when I did. And have we come a full circle? That's my question written down there. Have we come a full circle with bare metal stents, especially in treating left main disease?
No, actually, so that's very interesting. But then I read Dr. Antonio Colombo's editorial comment about that particular trial. So because that trial follows up patients over 12 years, which means from the era of before the first generation of DES and beyond. And our decision-making process also probably has evolved from that time to now. And because we consider our ability to do complex angioplasties and our confidence in the current generation of drug-coated stents, and with the availability of the aggressive pharmacotherapy, our decision-making may be more aggressive. Whereas patients who underwent distal left main bifurcation treatment with bare metal stents in the beginning of that trial, at that time, cardiologists may have been more hesitant to take up very complex distal left main bifurcation. So the nature of the anatomy in those patients who were treated with bare metal stents versus those who were treated with drug-coated stents much later on would probably have been very different. And that's why you see that the bare metal stent outcomes at that time versus CABG seemed acceptable, whereas drug-coated stent. So it's all about the right kind of decisions for a given anatomy that influences the outcomes.
I think it's evolutionary selection bias, evolution of the procedure and selection bias.
I think the controversy of provisional versus two stents remain. Europeans saying that provisional, EBC main says provisional is better, DK crush 5 and 6 and all showing this one, because I think the criteria, definition to criteria of simple left main bifurcation or a complex left main bifurcation, then only you can compare one strategy to the other strategy. You may say that I get a perfect left main results, other people say with provisional I don't get a good result, because what you are talking left main is different, what I am talking left main is different. I think that is very important. Simple left main bifurcation, what definition to trial criteria are applied, then you can say that, okay, two stent strategy in a complex is better. If you do a simple provisional in a complex bifurcation, your results will be bad. So I think, as you said, circ osteal lesion or a RCA CTO defines whether the left main patient will go for surgery. As you already said, a downstream lesion. Those are the, if isolated left main, yeah, you already showed all the results and this one. But getting a good result, patient going home is definitely better. And only thing is repeat revascularization. We can't compare the Lima results versus our stent results in the left main. Thank you very much.
Yeah.
Request the panelists to take the session. Dr. S. Kumar, sir, Chief Consultant, Interventional Cardiology, Kauery Hospital, Trichy, to come on stage. He will be talking about no free flow phenomenon in primary PCI. Sir is a highly experienced cardiologist and has contributed his research services in various medical societies in India and abroad.
May we request the speaker to be restrictive in the duration so that we will minimize the loss of time as requested by the organizers. Thank you so much.
Respected chairpersons, respected seniors, my dear friends, thanks Kauery Group for giving me this opportunity. Next few minutes, I'll try and restrict my talk to the limited time, sir. Next few minutes, I'll be talking on no reflow in primary PCI. So okay, I'll start with the case scenario. This is a 57-year-old anterior MI LVEF was thrombolized outside. It's not a primary PCI, it's a rescue PCI, but it almost the scenario is the same. So because this is the time duration which I'm talking about, 9:35, the patient had a angio and was waiting. And you can see the proximal to mid LAD had a critical lesion. So we want to stent it, and because it was not a primary, we just took time because some other primary came in between, and we stented the lesion at 11:05. And after stenting, this is the scenario, which most often a practice come across. So whether there is no flow in the LAD, and we in our hospital has a protocol of doing rescuing the patient after no reflow. Just give the initial injections of all like a cocktail of vasodilators and glycoprotein 2B3 inhibitor. But if it's not working, then we do a targeted revascular injection within the coronary artery with a thrombocytopenia catheter. Give all the cocktails and then aspirate and clear the pathway. And 11:08 was the time with which we did it, and 11:11 you can see the flow established. So why I am telling is time is muscle. So you have to ensure that whatever we are doing it, we have to do it very fast and ensure that we establish the revasculation TIMI3 flow very, very quickly. So that's where the outcomes are there. So the carry home message is establishing TIMI3 flow with a good myocardial vascular perfusion is very, very essential in our primary PCI. So no reflow phenomenon is nothing but if there is going to be inadequate myocardial tissue reperfusion in spite of not flowing epicardial, or if it is flowing epicardial, but it's not there, we are not able to achieve it, then it's not successful primary PCI. So we know it, right? A long back, almost 4 decades, we know it is primary. There is going to be some no reflow phenomenon from 1985 onwards. And the incidence is much more common in primary PCI and also in SVG PCI, as well as in after and plaque modification, rotational atherectomy or orbital atherectomy. So primary PCI, close to 10% of the people have similar type of slow flow or no flow, no reflow phenomenon, and we have to handle it. So what is the outcome? See, no reflow, when it occurs, the outcomes are much worse. See the bottom of it. The survival is much worse, even though the patient comes on time, and if you are able to show them the epicardial flow, it is much worse when there is going to be no reflow. So it's much lesser. So in-hospital mortality is much higher, almost 3 times more mortality with 12.6%, 3.8% in-hospital mortality. Reinfarction is higher. Obviously, resolution of ST segment is not there. Patient going into cardiogenic shock and requiring supportive therapy is very high, and long-term heart failure is also very, very high. So we need to understand no reflow and diagnose it and treat it very early. The simple thing is if it's not flowing and you are not seeing all branches of the coronary artery but getting vascularized, then you have to act very quickly and you have to ensure that opening of the microvasculature by all means. This is what the ultimate treatment is all about. TIMI grade less than 3 and corrected TIMI frame count, myocardial blush grade. So everything suggests that you are on the table, you decide on no reflow, and we have to be aggressive in your management. So what is the heterogeneity? See, this is the whole idea of no reflow. The central area is the already infarcted area where we cannot do anything about it. But the surrounding area of ischemic penumbra, the infarcted no reflow, low reflow, that's not no, low reflow, where we can try and open. That's the ultimate idea. Stun hyperemia over a period of time, it is going to reopen, contract again, and it's going to come back. And normally, this is the area, this is the yellow area is the one which
we have to target and get the myocardium active. So what are the pathogenic and what does it contribute? See, something is in our hands, something is not in our hands. The patient's inflammatory response due to a higher ischemic time. The door to needle time is longer, long ischemic time. Then that is not in our hands. And the reperfusion related injury almost related to the long ischemic time. These two things are not in our hand. But only thing what we have is distal embolization and spasm of the distal coronary artery. These two are the one which it is in our hands for our treatment. So these two things are to be targeted much more, and we have to educate. We have to bring every resources to ensure that the door to needle time from inside the hospital setup is very short, but distal embolization and spasm of coronary artery is there, which we have to treat. So coronary occlusion, long duration can result in endothelial damage and the thickening of the endothelium and interstitial edema can happen, narrowing of the distal coronary artery and microvascular obstruction can be there, and reperfusion related oxygen-free radical injury can be there. These are all things which is very difficult to handle, but arterioembolism is the one which is our hand, and more and more concentration should be there on treating this low reflow. So what are the distal embolization components? Platelet aggregate activation, thrombus embolization is the prime thing, and plaque particle liberation. These are the two things which it's technically which demanding and which requires attention from us. And definitely more and more no reflow, and it's going to be painful for the physician to attend. So what are the areas we need to concentrate upon? So I kept on talking about vasoconstriction. This is the probably neglected area from us, because in acute MI, there is a sympathetic activity is very high. Usually the coronary artery size is narrowed by 10 to 20%. This is one thing which the selection of stent matters in this place. So vasoconstriction component is one thing which is there, and there more and more thrombotic lesions are there, mean that is more and more aggregates and more dilatation of the vessel with a stent and post dilatation is going to release more thrombotic material from the subintimal space, and distal embolization mechanically can go and occlude the small vessels and micro vessels and can cause problem. So who are likely to have more reflow? Just to start with. So when the patient is elderly age and long duration ischemic time, elevated blood glucose, long lesion, higher reperfusion time, low flow grade prior to primary PCI, and higher thrombus burden prior to. See, these are to straight away start with. These patients are likely to have a higher poor outcomes and higher no reflow phenomenon. So the individual susceptibles is hyperglycemia at the time, say DKA or at high 300, 400, likely to have no reflow, much more common. And that's the reason why I used to start with the insulin infusion straight away whenever I see a higher blood glucose level. And loading dose is very, very essential. Statins are very essential to stabilize the plaque, and lack of preconditioning is another thing. Pre-infarction angina is much more safer than a first-time virgin acute pain. And distal embolization thrombus burden. So this is the ischemic duration is going to be difficult, handling is going to be difficult, and distal embolization is the one which we are going to target again and again. The short, acute, and long-term chronic effects are much worse. Acute MI, acute cardiogenic shock, ventricular arrhythmias, and patient refractory arrhythmia and death, and 3 times more mortality is the one which are going to handle. And once in the long term, the patient is going to have severe LV dysfunction and is going to have managing chronic heart failure is going to be a painful thing in future for the patient. So how I am going to handle it? So coronary occlusion, once it is there, then you have to understand prolonged ischemia, pray that we should not happen to our patient. If it is going to happen, it is going to be difficult. So the plan is load them with the antiplatelet right away and prepare the mindset. When the predictors are there, more age, more than high, long duration of ischemia, and the patient has a hyperglycemia, prepare yourself for a potential thrombus aspiration and multiple glycoprotein 2b3 inhibitor. And you have to have a cocktail of vasodilators in your lab. That is most important. And your lab should have a protocol of giving what the medications you need to give. As a cardiologist, the support system should be well prepared to handle the scenario. The whole initial slides of my case was to know within 3 minutes, we can establish the flow when you have a crisis. That's the most important outcome, which is in treating a primary PCA. So we have to be much prepared for antithrombotic, to have a low threshold for using glycoprotein 2b3 inhibitor and vasodilators, which will be there. So how we are going to do it? So whenever there is going to be slow reflow, first think ourselves if there is any mistake from our side. Is there any dissection? So given the stent has dissected, then that could be a reason. So just to ensure that dissection is not there, treat potential spasm. Give them nicorandil, whatever is available in a cath lab, straight away give them nicorandil, nitroglycerin, whichever is there. You just start giving it and see whether there is a potential vasospasm and you can come out of it. And whenever you are going to do a atherectomy, rotational or orbital, I find orbital has got more no reflow than rotational. So this orbital atherectomy and rotational atherectomy, you have to ensure that I start. Yesterday when I did a orbital I started prior to the procedure nicorandil infusion. So these are something which I modified my technique in such a way that I anticipate no reflow and start microvascular opening drugs. Intracoronary microvascular therapy, which is very, very important, which I'll come in the next slides. So when there is persistent no reflow in spite of all these things, first do all the first things. The first three things are very, very essential. And whenever you have a large thrombus burden, even though the current guideline says use of aspirin thrombectomy, when you visualize angiographic long thrombus burden, straight away I take aspiration catheter. There is no doubt in my mind, put a aspiration catheter, give the injection, all the cocktails straight into the deep into the intracoronary artery, and then start aspirating. And once you aspirate, you just clear the pathway and you are establishing the microvascular flow much easier. And the patient is going into slipping into shock, do not have hesitation in starting IABP and whichever the support system you have. Repeated injection, either with the aspiration catheter or with the micro catheter deep into the coronary, gives you much more satisfying result than the intracoronary injection. And glycoprotein 2B3 inhibitor should be started. What is the protocol in our lab? We always give nicorandil as the first line of therapy. For nicorandil 2 milligram or 4 milligram straight away injection within the coronary artery, into the coronary care, not in the main injection. It is put a thrombus aspirin catheter or a micro catheter or even a punctured balloon technique. When it is not available, patient is not affordable, do it. Take a 2 mm balloon, inflate, puncture it, then take it deep into the coronary and inject all the whatever the drug medication into the deep into the coronary artery, which is a much cost saving. Okay, what we do is you just have nicorandil as a 2 milligram injection, then adenosine 100 microgram. You have a preformed dilution preparation, which is there in the as a formula we given to the nurses. They'll give adenosine, which is kept. Adenosine is a very, very potent vasodilator. RCA, you have to be very careful, but if it's non-dominant LCX and LAD, we are very happy to give without any major obstacle. Just give adenosine. And if it is not working, sodium nitroprusside or sometimes when it's finally not working, I used to give adrenaline as well. So these are the protocol with we work on, and glycoprotein 2B3 inhibitor, whichever you are comfortable, you have to work, start giving multiple infusions and boluses and then start as an infusion. So is there any role for thrombus aspiration? Definitely. When you visualize a thrombus in the coronary artery, you require to do a thrombus aspiration. Routine aspiration on every patient should be avoided. That's one thing which is there. But when there is going to be a visualized thrombus, you have to necessarily give a thrombus aspiration, and putting a distal protection device is not advisable. That is not like, it is not like a carotid stenting. You put a thrombus distal protective device and start doing it. It's nothing to do with it. It is not going to work in coronary. So how do you manage distal embolization is the one which is going to be the ischemia, reperfusion injury, duration of ischemia, nothing in our hand, reperfusion almost proportional to this thing, but still we have to work on it because the endothelial thickening, interstitial edema, vasospasm, narrowing of the distal micro small vessel. These are the things which is going to have a poor outcome. Try and open everything. Give adenosine, nitroprusside, verapamil, nicorandil, everything, whatever is possible. You just try and give glycoprotein 2B3 inhibitor, low threshold for using it. And whenever it is there, so by giving all this lower threshold, you always try and have a radial approach during acute MI situation, so that you reserve the groins for any IABP or anything, and you also have a less hemorrhagic complications. So these are things which you have to start practicing and do it in a routine way, and it becomes a practice. And after that, your team is well much tuned to do it time and again. So when there is going to be a high thrombus burden, prepare for a thrombus aspiration and all the cocktail of medication, low thrombus burden. How do you stent it? So now you know a lot of medications are going to work. How I approach the stenting? So I told you vasospasm component is 10 to 20% vasospasm is going to be there. You might be underestimating the stent size when you are picking up it. So how you are going to do it? I always take 0.25 millimeter most of the time, more than the vessel size, and deploy it in a normal pressure, nominal pressure, not going to a higher inflation. Higher inflation stretches the subendothelial space, invites all the thrombus within the vessel wall, and has a distal embolization much more frequently. So what we have to do is take 0.25 millimeter, higher size stent, more than vessel. You take care of the component of vasoconstriction as well as prevention of over dilatation, so that you do not invite the subintimal thrombus within the vessel wall and cause more problem. So larger size stent, try and cover end to end. Do not leave the thrombus. Try and cover end to end. Nominal pressure. Do not try and post dilate to with a higher pressure, 22, 24. Like that, do not go for a higher pressure. Whenever you want, you go to the nominal pressure for post dilatation as well. So these are some of the tricks which we have practiced and we have been successful over a period of time. So STEMI, routine aspiration, avoid. So you see a large thrombus, please do it. Do not use a distal protection device. Always use ticagrelor in primary PCI. Do not think about anything. Forget about clopidogrel. Prasugrel reserved for possibly a diabetic population, recurrent stent thrombosis, something like that. Most of the time, ticagrelor is the one with aspirin and loading dose of statin. And low threshold for using glycoprotein 2B3 inhibitor whenever you see a large thrombus burden and no reflow. And routine filter use is not advocated, and perhaps direct stenting whenever is possible is better. And you also know that it is not going to be a calcified lesion, it's a fibrothrombotic lesion, and which is going to respond to your deployment of stent much easier. So copious vasodilators, you need to do it completely. Time and again, but you can repeat it because your actions of all the medications are going to be 2 or 3, whatever you are going to do the acute emergencies, it's not going to hamper your hemodynamics. So you can use it. SVG grafts is a different ball game. Whenever you are going to use, you can, here in this case, you can use a distal protection device and do a larger stent, whatever is required, try and deploy it nominal and come out. Atherectomy devices, I started using vasodilator, my microvascular dilator, Nicoran infusion as well. On top of it, you are going to have a infusion within the vessel wall as well. And when there is going to be a severe LV dysfunction, you know that's going to be a LV wall is much with the edematous, LV dysfunction, LV EDPs on the higher side. It is going to have some sort of a slow flow. Even there is going to be microvascular opening. You have to have a cautious approach. You have to prepare yourself for IABP or some other support and start doing the procedure. And no reflow is associated with larger infarct size, poor outcomes, reduced ejection fraction, and higher mortality. So you have to, at some point, at all point of time, you have to ensure that the patient has TIMI3 flow at the time of wheeling out of the patient from the cath lab. This is the most important lesson we have to have to prevent no reflow. Long door to balloon time should be avoided. Longer stents, very long, 50, 60 minutes should be avoided. Higher pressure stent deployment should be avoided. When there is going to be angiography evidence of thrombus burden, intracoronary thrombectomy may be used when you visualize the thrombus, and distal protection device have less proven long-term benefits. When no reflow is recognized, pharmacological intervention proves beneficial. Definitely lytic of medications are there. Distal coronary infusion with either your distal aspiration catheter or your puncture balloon technique or your microcatheter is very, very useful. So this is what the summary, whatever I have told. Start early, shorten the duration time, shorten the logistics, get the patient into the cath table much faster, have a cocktail of medication, anticipate the problem, treat it. Thank you for your patient attention.
Thank you, doctor. Nice presentation. Suppose you have a slow flow, you have improved, you see that the stent is under expanded. What will you do there?
Yes, sir. This is the reason why I straight away start doing with a higher stent deployment.
No,
One thing.
suppose
And suppose it is not, okay, it is there, a slow reflow. Then the first day, most of the time, I don't take the patient the second time in the cath lab, but when it is required, I just treat the patient on the given day. Next day morning, when thrombus burden is lessened, I take the patient for a check angiogram. You do a imaging and ensure that I deploy the stent in the post dilate and ensure that after thrombus burden has settled down, I start doing it.
Yeah, most of the time slow flow happens, stent deployment is good, result is good, You do post dilatation, then you will have a slow
So
flow.
that's the reason, sir. That's the reason. Always with the experience, what I do is I tend to take a higher stent size and deploy it nominally where the incidence of no reflow is much lesser rather than trying to do a stent and trying to post dilate to achieve the desired results.
Thank you, thank you. And I think of all the drugs, I feel IC adrenaline is the most potent.
The last
If
medication
nothing-
which always I
nothing
use is
works, IC adrenaline works, but I bring a defibrillator forward because whenever you use IC adrenaline, VTVF is going to be very high. And sometimes 20 mics of adrenaline is very sufficient to push the pressure from 90 to 200. So, but many times we'll have VTVF. A nice presentation. Thank you.
Thank you, sir. Thank you, sir.
Thank you, sir. Now I request the panelists to give a token of appreciation to our speaker. Sir, next up, we have Dr. Suraj Narasimhan, who is a consultant interventional cardiologist from Narayana Health City, Narayana. He is a specialist in interventional cardiology and structural interventional specialist.
A very good morning to everyone. I'd like to thank the organizers and the Kauery group for giving me this opportunity to talk on OCT in complex cases. So we'll be seeing something regarding what is complex PCI. There is an algorithm called MLD max algorithm, and how this OCT impacts the procedural techniques, real world cases, and are there any studies to support the use of imaging in these kind of complex cases. So any true bifurcation lesion with the side branches more than 2.5 millimeter comes under complex PCA, chronic total occlusions, unprotected left main disease, severely calcified lesions, ostial coronary artery disease, instant restenosis, and long stents. When we use long stents, they also come under complex PCA. So the basic problem with an angiography is a luminogram. So we get to see the lumen, and then we don't get to see what is the block characteristics, what is the morphology, and we don't get to see the extent of disease as such. And also, after we implant a stent, we are not able to assess the results of the PCI, which is which is most important as it is. So the intravascular imaging like OCTs and IVUS gives us an idea regarding the block morphology, what kind of stents to choose exactly, and what is the post-PCI optimization which is required to have the better long-term effects. So we have this algorithm called as the MLD max, which we use for all OCT guided imaging. This is a very simple algorithm. We do a pre-OCT run. We see the morphology of the block, what is the length of the stent which is required, and what is the diameter of the stent which we have to implant. After we implant the stent, we have to use the max algorithm to see whether there is a medial dissection, how is the opposition, and how is the expansion of the stent. So this is a simple algorithm which includes all the characteristics and parameters which is required for getting an optimal result post PCI. So morphology of the block can be starting from a simple lipid block to a fibrous block, and it can be a moderately calcified block like this with a 180-degree of calcification, and a severely calcified block which we see over here. If it is a simple lipidic block, we can just directly stent without any dilatation which is required. And if it is a fibrotic block, probably a semi-compliant balloon will be more than sufficient. Moderate, mild calcification, NC balloon dilatation, and in severe calcification will require an orbital atherectomy or IVL. So these kind of morphological basis of the lesion, we don't get in an angiogram per se. Because if the calcium scoring is more, when the calcium is more than 5 millimeter long and thickness is more than 5 millimeter, and also if it is covers the arc of calcium which is more than 180-degree, then the stent is going to be underexpanded. We'll like to use some orbital atherectomy or an IVL to treat these kind of calcified lesions. Then we have to find the optimum landing zone because we don't want to do a geographical miss. So this is what usually happens in an angiographic guided PCI. We don't get to see the exact extents of the disease, but then in OCT, we'll be able to realize what is the exact extent of the disease, and then we'll be able to select a stent size. So the easiest thing is that wherever we see the triluminar area, so we can use that as the landing zones, and then that will be helpful enough to get a proper landing zone. So this is the luminogram which we get in OCT. You see where you have the proper lumen and whether you are able to see the EEL at least 180 degrees. You keep a marker over there, so that will be a distal landing zone. And then select a proximal landing zone, and then whatever distance in between, we get the length of the stent which is required for implanting. So the second thing length we can get by this way. And then according to the sizing, we have to use the EL to EL diameter if possible, and then downsize it by 0.25. Or if you are going for the luminogram lumen profile, then probably upsize it to the nearest stent possible. So we have the morphology, we have the length of the stent, and then we have the diameter of the stent. So this is the pre-procedural protocol which we have to do. And after the stent, we have to look for dissection. So the dissections will be leaving out minor dissections or non-flow limiting like dissections like an intimal dissection. If it is extending into the media, or if there is a hematoma and the lumen compromise, we have to put a stent over there because these stents are going to get blocked in long term. And then the most important thing is the apposition and also the expansion per se. If we have a stent which is hanging like this, not opposed to the vessel wall, there is an increased chance of stent thrombosis in these kind of patients because endothelialization doesn't happen even in long term. So if we have an under malapposition, like if it is more than 0.3 millimeter, 300 microns, this has to be treated per se. And we have this apposition indicator. It's a simple thing. If you see all white things, your apposition is good. When we have a red thing like this, that means to say that your stent is not opposed to the vessel wall, and this has to be post dilated to make sure that it touches the valve so that you don't have any stent thrombosis in future. So coming to the expansion. Expansion, you have to achieve at least 90% of mean reference lumen area. If not in severely calcified lesions, at least 80% has to be aimed. Once you get this, your stent is very, very well expanded and very well opposed, you can go ahead. So this is a simple algorithm. See the morphology, select the length of the stent, do the diameter of the stent, and after putting a stent, look for dissections, expansion, and also the apposition per se. So this hardly takes around 5 minutes extra rather than a regular angioplasty in labs which routinely do this. And most of the time, my technician will be able to give this small information rather than be going and looking at the monitor per se. So everything is done. So when we put this algorithm, it has been found that 83% of the time, the pre-OCT pullback is going to change our stent strategy. And after you put a stent, 30% of the time, your post-OCT pullback is going to ask us to do something more. So that much of impact this MLD max algorithm and use of imaging has. So we will be seeing a morphology which we did not expect in the angiogram in 48% of the time. Predominantly calcified lesions are the most important one. And then we prepare lesions much better. And then we change the stent length and also the stent diameter by around 38% of the time. And after we put a stent, we get edge dissections, which we don't get in angiographically significant around 4% of the time. And we see 25% of the time there is under expansion of the stent. So pre-procedural 83%, we are going to change our decision. Post-procedural around 31%, we are going to change our decision. So after looking at the morphology, 50% of the time, probably predominantly because of calcium, we'll be using a cutting balloon or a scoring balloon. And sometimes we don't even have to prepare in a lipidic plug so that we directly go ahead with stenting. Same thing happens with the diameter. Angiography, around 16% of the time it overestimates the vessel size and 22% of the time it underestimates the vessel size. So your stent is going to be changing by around 0.25% in 38% of cases. And expansion, as we already saw, 25% of the cases will have under expansion, especially if it's a calcified lesion. In complex cases, that is more common. this under expansion is going to lead on to stent thrombosis and instant restenosis, and IVUS and OCT is going to help us guide in preventing this under expansions. So put together, pre-impact is there, post-impact is there, and our strategy is going to change by around 88% of the time if you use an OCT guided angioplasty. To see some clinical cases, this is a 56-year-old male who presented with anterior MI, lysed elsewhere, and then he came with mild LV dysfunction to our hospital, hemodynamic seal. He had a successful thrombolysis. He is a hypertensive and a smoker. So this is the angiogram which we did. Right coronary artery was essentially normal. There was no significant disease. Coming to the left coronary artery, we can see that there is an ostial LAD critical lesion. And circumflex also had minor disease in the distal portion, probably doesn't require any treatment per se. But in angiographically, we can see that there is a significant amount of calcium over there. So it is a double vessel disease with an ostial LAD lesion which is calcified. There is no obvious left main disease. Circumflex had minor disease for medical management, and syntax score was less than 22. So basically, it is a case for an angioplasty. So we thought that we'll do an OCT guided angioplasty, and based upon the calcium, we will see whether to do use an IVL in this case. 7 French access, EBU, 7 French guide, 2 mm pre-dilatation, OCT pre-run, circumflex and LAD. Look at the plaque burden and decide on using whether IVL or a scoring balloon, and a post-run to assess whether we have adequately prepared the bed. This is what is more important. You see calcium, you treat it, and then you have to see whether whatever treatment you have done has worked. So lesion preparation is more important, and a post IVL and OCT orbital atherectomy or a rota run of OCT is essential to see whether you are prepared. And this patient has an ostial LAD, so it requires a left main to LAD stenting. And circumflex did not have much of a disease, so provisional strategy was used, and kissing balloon dilatation if required, and a final OCT run in the LAD and LCX to look at our results. So this is our LAD run, which we can see that the distal portion of the LAD has a triluminal area, and these are the branches, septals and diagonals which are coming over there. And this is where the disease starts. We can see that the calcium started from here, around 180 degree of calcium. Here we can see almost 360 degree of calcium with a significant thickness of calcium which is over there. And also the length of the calcification was also higher, around 28 millimeters was there. So more than 180 degree, more than 5 millimeters, and also 500 micron. So LAD requires some IVL or an orbital atherectomy or a rotablation. So this is the circumflex run. Circumflex was fairly free of disease. This is the circumflex ostium, which we can see over there, had some minor disease over there with the lumen area of around 3.5. Left main is totally free of disease. So we thought this is the distal landing zone, 360 degree of calcium, ostium circumflex is involved, and LAD is significant and circumflex has minor disease. So according to the algorithm, it was a balloon uncrossable lesion with all the 3 features of severe calcification. We did an IVL, which is what is recommended. And this is the IVL 3x12. And we can see that there was a dog warning. After 60 pulses, we were able to nicely open up the calcified lesion with a 3.25 NC balloon. And after that, we did a run to check whether we have created adequate lumen in our OCT. So for want of time, I'll skip that. So we can see that there are significant amount of calcium cracks which we have created in the calcium because of the IVL, and we have prepared the bed well. So we took a stent which was 3.5 into 38 mm, placed it into the LAD from the left main, keeping an adequate distance for pot. Then this is the result which we got. Then we did a 4.5 millimeter pot in the left main, recrossed the lesion into the circumflex. The circumflex ostium was looking a little bit hazy, so we wanted to do something for that. So we recrossed it, and then we did a kissing balloon dilatation, and then we did a repot, and even after that, we were not happy with the result. So we used a DEB kissing technique, 2.75 into 20, because circumflex ostium had a lipidic block. And finally, pot was done with a 5 millimeter balloon, and this is the result which we got after the stenting. So we had some distal dissection, but then it was not extending into the media or not we have a good lumen area, and so we did not want to go ahead with that. And good luminal expansion of the stent was that the left main circumflex ostium was looking very good. So this is the 3D view, which we can see that there is a well open circumflex, and the LAD and the left main stents are all well opposed. So this is the final result which we got. This was done probably a year back, and the patient is doing very well without any complications. So we'll probably skip this case. This is the case of ISR, which was there. So we found out that ISR was because of geographical mismatch, and also there was a neoatherosclerosis which is formed inside the stent, which is around 2 years old. This was a first generation drug-eluting stent. So we can see that there is a neoatherosclerosis which has developed over here, and the previous stent probably they missed the distal portion of the and the proximal portion. Probably that is the reason why this stent got blocked. And we did a high post dilatation, and we covered it in the stent. This is the final result which we got, and we were able to take a 2.75 stent just because of the imaging per se. There are some studies which are helped us that given us some guidelines regarding this complex PCA. If we use imaging, what we see that is our MACE rates are going to come down by around 50%, and your CV death is going to reduce. The target vessel MI is going to reduce by 50%, and the target vessel revascularization has also come down. It can be either with an IVUS or an OCT, but there is no direct comparison. Even in direct comparisons, we don't have that much of data to say which one is better. So finally, to conclude, I'll say that we'll skip this. Angiography has limitations while assessing the lesion. Imaging is going to help us in strategy for lesion preparation, how to prepare a proper bed, and how to select a proper stent, and then how to optimize a stent properly. And this is ultimately going to give us long-term outcomes, especially in complex cases. So in all complex cases, it is advisable to either use an IVUS or an OCT to have a better outcome in our patients. Thank you.
Thanks for the wonderful presentation. Thank you for all of the discussion. Identify yourself and ask the question.
So ostial left main is ostial LAD is actually a tricky situation wherein imaging is most helpful. The first thing which we have to image and see is whether the left main is also diseased or not. In our case, actually, left main was totally free of disease. The second thing which you have to see is what is the disease extent in the circumflex. The circumflex is going to be a dominant circumflex, or whether there is a disease in the ostium. So in this, our patient, the ostial LAD had disease, left main was totally free, and circumflex did not have much of a disease. So this syntax score is going to be less than 22. It is a single vessel disease. Probably he will also do better if done with a proper imaging, in like what we did in our case. And always it is better to do a crossover stenting from left main to LAD in any ostial lesions, because if you try to exactly place the stent in the ostium, you are going to miss it. If you miss it if you come into the LAD, your LAD stent is going to have a problem. If you protrude too much into the circumflex, your circumflex is going to end up in a problem. So the best thing to do is you start from the left main, push it into the LAD, and after that you see if you have stents which are hanging in the circumflex ostium. If the stent struts are there in the circumflex ostium, you have to do a kissing balloon dilatation, which is going to take away all the stents from the circumflex ostium. So your circumflex ostium is going to be free of it. So like what we did in our case, always go for a distal cross and do a kissing balloon dilatation, push everything away. Since this patient had less of a burden in the left main and circumflex, I think this is also an excellent strategy for treating such kind of patients. And this is not a complex bifurcation stenting. It is a simple stenting with an IVL with a single stent and a kissing balloon dilatation. And then we took care of the circumflex by using a drug-eluting balloon, which is not also going to leave any metal. In future, if at all these patients have a stenosis, it is unlikely that we got a very good result. But then the circumflex is free of this risk and we can, less metal is there, we can go ahead with the bypass or anything else in future. Or if we require another PCI, also it is possible because the metal layer is going to be very correct. Actually, what I prefer is all my listenings, I do some kind of imaging. All my stent failures, I do some kind of imaging. And if it is going to be a complex bifurcation strategy, we do imaging. And especially in this kind of osteal LAD, circumflex disease, imaging is important. And this is not going to be time consuming per se. Probably it will add around 5 minutes extra. But then the knowledge which we get out of doing these cases, we will refine our techniques and then we'll be able to achieve better results in most of the cases.
As we're running short of time, I request all the speakers to stick to the time limit of 10 minutes. Next, I'd like to invite upon stage Dr. Vivek G, Senior Consultant Interventional Cardiologist, Kauery Hospital, Electronic City, Bangalore. Sir is a highly sought after interventional cardiologist who specializes in adult and pediatric interventions, pacemakers, including CRT. Thank you.
At the outset, I'd welcome you all to the Kauery Annual Heart Summit. Now, we already know from what Dr. Sanjay and the others said, complex PCIs, the chip PCIs have become a part of an interventionalist dream now. So we tend to do more and more of complex cases. Now, one arm of doing a chip PCI is the hemodynamic part. We already spoken about a little bit about the rotablation, the imaging part. So I'll just briefly focus on the hemodynamic part. So what exactly are these high-risk patients? So these patients are patients who are prohibitive. They are not able to undergo a surgery, or patients who refuse a bypass surgery. Now, procedural hemodynamic stress poses a significant challenge, and especially in a patient whose myocardial reserve is less. These patients who are elderly or are extremely frail, these patients tend to need some kind of a hemodynamic support. Now, the emergence of new mechanical circulatory support devices has made PCI a more viable option for these high-risk patients. Now, protection is definitely warranted in all part of life. Now, what exactly is protected PCI? This is basically a term which we have coined for high-risk PCI, where we use mechanical circulatory support. Now, it can be in an elective PCI or in an emergency PCI or a cardiogenic shock. In a patient who is in a cardiogenic shock, there's no-brainer. We have to use some sort of hemodynamic support. Now, predominantly, I'm going to restrict for the use of hemodynamic support in patients who are undergoing complex elective PCIs. Now, this is where there's a lot of controversy. Like we began by saying that chip PCI, whether we should do a a part revascularization or a full revascularization. The whole point of doing a chip PCI is that we should ensure that there is complete revascularization. That's why we aim to use hemodynamic support and try to achieve it. Now we do it to reduce the symptoms. We try to improve the class of heart failure, improve the LVF, avoid acute kidney injury, decrease the number of days of stay in the hospital, and mainly we tend to see whether any usage of these MCS will actually decrease the MACE. So that's what is more important. Now, it's a combination of characteristics for the patient, whether the patient is an elderly, is in heart failure, he's a diabetic, he has extensive peripheral vascular disease or undergone a prior surgery, and also the anatomy of the coronaries, whether it's a multivessel, diffusely calcific vessel, unprotected left main, or multiple CTOs, and the baseline hemodynamics, whether just because he has an LVEF of 35%, if he's well compensated, you don't need to use you don't need to use an MCS. Where patient is hemodynamically unstable, he has a decompensated heart failure. So these patients definitely need hemodynamic support. In between these are those elective PCI patients who will actually benefit from a complex chip PCI with hemodynamic support. Whether we have evidence for that or not is what I'm going to elaborate a bit. Again, what is the criteria for high-risk PCI? Again, patient-related criteria, comorbidities, age, heart failure. Again, whether it's a multivessel, unprotected left main, CTO, calcified lesion, and then the hemodynamic status. The patient has an increased LVEDP, an impaired cardiac output, a lower mean arterial pressure, an anticipated prolonged ischemic time, and a large area of risk. Or the patient is having ventricular arrhythmia. So these patients tend to do well with hemodynamic support. Now, how does MCS actually work in a protected PCI? So it decreases the wall stress, it unloads the left ventricle, decreases the LVEDP, and overall decreases the myocardial oxygen demand, and it increases the cardiac output, increases the coronary blood flow, and increases the mean arterial pressure. So increases the oxygen supply. So this is how the basic MCS work. Now, we should always remember, as soon as a new technology is introduced into the market, there's a tendency to overutilize them. There's also a tendency to underutilize them because of lack of expertise. So we should ensure that it's not over or underutilized. The most important thing to consider when using this device is the patient's physiology. A very complex technical case with a reduced EF, but he's absolutely fine, well compensated, does not require a MCS, whereas a simple lesion or a long lesion, which can be easily done, but he is having borderline hemodynamics, may warrant an MCS. So it's very important how you select the patient. The most of all the trials, of all the studies which I have done, the most important criteria is an elevated LVEDP. Whenever a patient's LVEDP is elevated or he has a low cardiac output, they are at a risk. When you start doing rotablation in these patients, when the BP drops, when they develop VTs, they tend to go down. It's always important that clinically indicated revascularization. That's what we discussed in the first talk as well. And there is actually no selected threshold where you should actually start using. You have to use a lot of your guide, whatever I'm going to say in the next slide, to actually decide whether whether this patient needs a protected PCA or not. A simple algorithm is this, where you see whether the cardiac index is low, the syntax score is high, ejection fraction is less than 25%, the blood pressure at the beginning of the procedure is low, whether it's an ACS presentation, where you're trying to revascularize more than 2 territories, where there's a prolonged ischemic time, where you're going to use a lot of wires, you're trying to open a CTO or using a rotablation, whether there's a severe MR, whether the patient is in a decompensated state, or hemoglobin is low, or there's a significant vascular risk or significant bleeding, then we can't use MCS in these patients. So if the score is high, then you strongly consider support. Now, this is the commonly used MCS for protected PCA. The most commonly used one in all the cath labs is IABP. The ones which is now being commonly used now more frequently is the Impella and the ECMOs. The tandem heart is more of historical significance. So IABP, the most commonly used one, works by counterpulsation, increases the aortic pressure, decreases the LV afterload. Again, increases the myocardial oxygen supply, increases the cardiac output and decreases the oxygen demand. Now, this is a very simple way of introducing an IABP. It just needs a 7 or an 8 French sheath. It's a safe option for patients who don't have a significant peripheral vascular disease. But the only drawback of IABP is it actually provides a very little increase in support. It gives you around 0.5 to 1 liter per minute of support. But it also depends, as we see in our acute extensive anterior wall MI setting, when we use an IABP, it actually needs a little bit of LV pumping, the rhythm to be okay. The rhythm is very erratic, a lot of arrhythmias going on, the IABP actually doesn't work. Some of the trials which was done with IABP in patients, the high-risk PCI subgroup, the BCIS1, it actually showed no difference in survival. There was no improvement in the MACE. But what they observed in the study is the use of IABP helped maintain blood pressure throughout the procedure. You could shift the patient to the ICU in a more stable state, but it actually did not give us any mortality or a benefit in MACE. Now, Impella is a very simple device. It's an axial flow where it takes out the blood from the ventricle and gives it out at the aortic root. It increases the flow, increases the aortic pressure, and increases the cardiac output. So it also decreases the LVEDP, decreases the oxygen demand, and increases the cardiac supply. So it's actually quite a simple device, but the cost is prohibitive. So here, Impella CP requires around a 14 French large bore sheath, most commonly inserted via the femoral or the axillary artery. It can provide support of up to 3.5 liters per minute. It lowers the LVEDP and improve the coronary pressure. So the 5 and the 5.5 device can provide up to 5 to 5.5 liter per minute output. Now, the whole concept of protected PCI and the trials are with Impella now. Some registry data were the US Pella and Europella. They actually didn't show a significant MACE benefit with Impella, but actually showed that overall hemodynamic stability was maintained. The Protect 1 and Protect 2, where they compared IABP with Impella again, they didn't show a significant difference in MACE when they actually analyzed it initially. But when they actually saw a lot of enzymatic infarction. So when they actually increased the troponin cutoff level, they actually saw that, okay, Protect 2 was, in the Protect 2, Impella was actually better and the MACE was slightly better. With that, they actually went ahead and did one more randomized trial called Protect 3, which got a FDA approval. And then now we are in Protect 4, where the Impella is being pushed to become a class 1 guideline recommendation. Currently, it's class 2B guideline recommendation for use of MCS in protected PCI. The ECMO, we know it gives an excellent cardiac output, and but there's a slight increase in cardiac oxygen demand when we try to use it in patients for elective PCI or otherwise. So one problem with ECMO is it comes at a higher bleeding rate and vascular complications, and you need follow-up intensive care, indwelling management, and trained and certified perfusionists maintaining it. So tandem heart, I told you, is of historical value. I would say the only place where you can use it is in the presence of LV thrombus, severe AS, or a mechanical aortic valve. So again, for high-risk PCI, without cardiogenic shock or without ACS presentation, when they actually used ECMO and IABP comparison in these trials, there was actually no significant MACE provided by the use of ECMO, but it provided a great hemodynamic support during the procedure, and albeit with an increased vascular injury and bleeding risk. So this is a basic slide which shows us how much cardiac output is given by each of these devices, and a basic slide comparison of how all of these work. So some of the disadvantages of MCS is, contraindications of MCS is when, for IABP is when you have a severe peripheral artery disease or a moderate to severe AR, which is the same for Impella as well. And the bleeding and the vascular risk is quite high when you use ECMO, moderate in terms when you're using it with Impella, and very minimal when used with IABP. Obviously, the support also varies. Now, this is the basic algorithm for a protected PCI. Now, any patient with CHIP, complex PCI, if he is in heart failure, you have to consider a VA ECMO or an Impella at the beginning of the procedure itself. If he's not in heart failure, okay, you think is slightly unstable, he'll get away with an IABP, you can use an IABP. And if it deteriorates, you can upgrade it either to an ECMO or an Impella. If he's okay post procedure, you can actually evaluate, try to remove the IABP or the Impella. Now, patients who are very stable, you can explant the IABP or the Impella in the lab. If not, you give a low dose of inotrope or a high dose of inotrope, stabilizing for some time in the ICU. If he's still not recovering, then obviously you have to upgrade to an Impella or an ECMO in the ICU. Now, I would like to conclude by saying that routine use of hemodynamic support in protected PCI is actually based on the patient. Now, if the patient has, you want to achieve complete revascularization in a borderline hemodynamic patient, then you should consider it. The second thing is the cost effectiveness. Ideally, I would want something at the cost of an IABP for hemodynamic support, which is actually impossible. And the ease of use, if everybody could use hemodynamic support like IABP, it would be very nice. And the clinical competency, obviously, if we start using Impella more frequently, or if I use Impella once a year or twice a year, obviously the weaning process and the usage will be quite difficult. The patient number again for ECMO and Impella will matter in centers where they do a complex CHIP PCIs with Impella and ECMO. They're actually more competent in managing the complications, mainly the vascular and the bleeding complications. And obviously, with increase in use in availability of devices, we tend to forget that guidelines is what guides us in managing the patients. So we should ensure that we appropriately use the devices. We don't tend to overuse the devices as and when they're available. I would like to conclude my talk with this.
Thank you so much, dear. It was a wonderful presentation to giving an overview about the technology and what support you have. from the-
Next up, we have Dr. M. Prasanna, consultant interventional cardiology from Kauery Hospital. Dr. Prasanna will be speaking about cardiogenic shock.
Thank you, organizers, for giving me the opportunity. So the complex is topic. So there are a lot of developments happening in the cardiogenic shock. So I will try to restrict to the important updates which is happening over the last few years. So these are the areas which I'd like to touch upon in my presentation with respect to the sky staging. And there is, with the help of the growth in the machine learning, there is an definition happening with the shock phenotypical classification and the role of hemodynamic monitoring in shock. Then a bit about VA ECMO developments, and finally with the RCT updates, I would like to conclude. When you take up the etiology of the shock, almost cardiogenic shock comprises almost more than 60 to 70%. But if you see the etiology of the shock, the AMA-related cardiogenic shock incidence is a bit lesser, because as the years goes on, the more of non-ischemic and ischemic heart failure patients occupy the majority of the pie chart of the cardiogenic shock. This is again the representation. The cardiogenic shock gradually rises with the years passing on, but the mortality, if you see, even with the lot of development in advances happening, the mortality still remains at the 50 to 60%, which is very dismal. And the MCS use is also remaining in the stable around 10 to 15%. But the trend in the usage of the MCS has changed in the last few years. So there is a decline in the usage of the IABP, and there is an incline, and there is an increase in the usage of the Impella and VA ECMO seen. So this is again the same thing. Almost 1 in 2 individuals who will land up with cardiogenic shock die in the hospital, but we don't have any much RCT evidence for the use of either the vasopressors or PAC or Impella or IABP. We don't have any real large RCT evidence to support our treatment efficacy. And if you go to the sky stage classification, the sky stage classification helps us in providing a common language to evaluate the severity of the cardiogenic shock, starting from the A to the E. So it's well supported with a lot of studies. Bottom is the Mayo Clinic registry, and on the right side is the European registry, which is very well validated. So as the sky stage advances, the mortality keeps on increasing. And the updated concerns with the sky stage is it's not only for the initial classification. As the patient goes on with the illness, you can reassess the sky stage classification, and you can see whether the patient is recovering or if the patient is deteriorating. So you can able to project the trajectory of the shock patient. So it helps in the progression, assessment of the progression of the shock stage also. And if you see the stages, this is the cardiogenic shock working group. It doesn't have any significant definite laboratory variables or metabolic variables available in the initial sky stage classification. This is the cardiogenic shock working group. So which has given some variables with respect to the mean arterial pressures, the ALT levels, and with the usage of the drugs, we can able to classify more easily whether the patient belongs to which stage. And the interesting is, which is on the right side, most of these patients who will land up in sky stage B, 90% of the time they need to escalate the treatment strategy. So most of the time these patients will land up in stage C or D. So it's very important that any patient with stage B also, that is normotensive, hypoperfusion, or hypoperfusion normotensive. So these patients will definitely land up in advanced stages. So we should not neglect stage B. And the hemodynamic predictors, if you see the congestion, normally we tend to estimate only the cardiac output and peripheral vascular resistance. But if you assess the congestion profile mortality, those patients who are having an RV congestion profile or biventricular congestion profile, they have a very significantly higher mortality. So we should always try to assess the congestion profile also, whether the patient fits only in the LV congestion or an RV or biventricular congestion, as well as as the advancement in stage, sky stage happens, the more of an RV and biventricular involvement is seen. And there is an improvement in the cardiogenic shock phenotype. With the help of the machine learning and artificial intelligence, they have classified these cardiogenic shock subgroups into 3 types. One is in cardiocentric, 2 is in cardio-renal syndrome, 3rd is in diffuse metabolic, that's in cardiometabolic profile. So the mortality is also very higher for the second stage 2 and stage phenotype 3. So we can able to classify within the sky stage, whether the patient in the sky stage B or C, you can further classify them, whether they fit into class 1, 2, 3 phenotype. Based on that, you can able to risk stratify these patients, and you can employ advanced therapies for those patients with an higher risk. So this is an important paper which is published by Kapoor et al. With the help of the pulmonary arterial catheter, we can able to bring down the mortality, especially in those patients with stage D, sky stage D, even in MI as well as in heart failure trial. And sky stage C, in heart failure patients, the mortality is significantly reduced with the help of the PAC. It's not the PAC which is making the difference, but the amount of data that you extract from the pulmonary artery catheter, that is driving the outcome. So more and more of these patients, when they initially present with an hemodynamic problem, so more and more these patients, they stay in the cardiogenic shock, they land up finally in the hemometabolic shock. So our treatment aim should be start hemodynamic support in the form of an ECMO or Impella as needed, and try to avoid these patients deterioration into the advanced stages. So based on the hemodynamic guidance, we can able to decide which form of therapy is needed for our patients, whether they need an LV unloading type of device, whether it's an RV type of support of device is needed, or LV support device is needed, or in circulatory support is needed. So based on these hemodynamic parameters in the particular subset, we can select these devices. And as well as if you see, there is a significant heterogeneity in the use of the MCS devices. In the stage C, if you see, almost 40% of these patients, they require a need of an IABP. But in the advanced in the stage D and E, more and more of Impella usage, ECMO usage, and 2 MCS device usages become increasing. So this is then central shock algorithm. With the help of the PA catheter, we can able to we can evaluate the hemodynamic variables. You can see whether the patient is going in the hypovolemia or LV dominant or RV dominant or biventricular dominant. So based on the subsets, you can choose the therapy. So this is a cardiogenic shock working group where they have formulated an acute MI cardiogenic shock protocol. So any patients with more than LV EDP, you should try to support them with an initial Impella, then go on to an PCA. Then you can further evaluate the need for an RV support. Those patients with an LV EDP lesser than 20, you can do an PCA. Then you can evaluate the cardiac index. If needed, you can do an LV support or an RV support. The same thing for an heart failure patients also. If the patient is in a heart failure decompensation, if there's a hemodynamically stable, you can do an cath, you can assess the cardiac index, and you can support them with an inotropes or vasolators if needed an IABP. Those patients with unstable unstable cardiogenic heart failure, you can support them with an initial LV support with an Impella or an VA ECMO. Then you can assess the RV support also. So this is an app which was formulated in the cardiogenic shock working group, which helps us in treating the cardiogenic shock patients. So if you enter the list of variables that has been given in the app, it will help us in guiding which shock stage the patient is in, which hemodynamics, it can help us in calculating the hemodynamics like cardiac index, everything, and shock phenotype calculator. So it helps us in guiding the treatment decision. So this is an important paper which was published in JACC Heart Failure. So where they have studied cardiogenic shock, and this is the lactate is the new CKMB for cardiogenic shock. So we all know that the CKMB importance in cardiac MI. Similarly, the lactate. So any patients with presence with cardiogenic shock with an baseline lactate more than 6 or less than 6, you need not have to reassess them after 24 hours. You can always reassess them after even within 90 minutes after the cardiogenic shock. And if the patient lactate is not decreasing, if the patient lactate is increasing, then we need to speak with your multidisciplinary shock team and you need to escalate the support device. You have to consider them for an MCS usage earlier. Those patients where there is a lactate levels are reducing, those patients you can manage them with the conservative approach itself. So this is the graph survival, which is clearly showing that those patients who are having a lesser lactate and if the lactate is keeping on increasing, they have a very low survival. And I'd like to touch upon few aspects with the VA ECMO. This is an VA ECMO. Normally, we know the mechanism of ECMO. Normally, it pulls blood from the venous and it pressurizes the arterial tree from the femoral aspect. So what happens is it has to pressurize the entire arterial tree from the femoral artery. So what happens is if there is an hypoxemia, acute lung injury with hypoxemia, if LV contractility starts increasing, so there are more amount of deoxygenated blood will enter the cerebral circulation. So to counter that, we need to increase the ECMO flow, or you need to increase the oxygen saturation. So whenever the high flow, whenever you are increasing the ECMO flow to improve your cerebral oxygenation, what is the problem is you are increasing the afterload on the LV. So indirectly you are affecting the LV performance. So that's why whenever if you are trying to improve your cerebral oxygenation with an increased LV flow, you have to adapt an alternative strategies for an mechanical LV venting. You have to do an LV venting in the form of an Impello or IABP. And also studies have shown that starting VA ECMO with Impella, it reduces the pressure volume area and limits the myocardial damage. And also VA ECMO, the more the patient tends to stay in the VA ECMO, there it depletes the cardiolipin. So what happens is it results in cardiomyopathy. That's why you see a lot of patients who are on ECMO, they land up with a dilated LV with a non-contractile LV. So it's mimic an mitochondrial cardiomyopathy due to the deficiency of the cardiolipin. So they land up in similar to the picture what we see in Bath syndrome. And most of the time we see ECMO CS trial, a lot of smaller number trials. They are the ECMO benefit is almost mortality benefit is not seen so far. So the main problem is because of the complication rates happens because of the ECMO. So more amount of vascular injury, high stroke, kidney injury, LV dysfunction. So this drives the increase in the complications. So this drives the outcomes in these VA ECMO patients. So you can see a larger cannula sitting in the arterial and venous axis. So what happens is, so the larger axis that you use for an arterial axis, the more incidence of an acute limb ischemia. Any untreated acute limb ischemia will definitely land up with an 100% in-hospital mortality. So we should try to look for vascular complication mitigation strategies like impella sidearm or impella post-closure on a single axis PCA, or salvaging the distal perfusion by use of an antegrade perfusion. We have to work upon the complication for the vascular complication mitigation strategies. So this coming on to the RCTs in cardiogenic shock. This is the RS trial, which they have studied ECMO versus standard arm care. Those patients who have had an out-of-hospital arrest and ongoing CPR, here they have shown that ECMO is significantly better when compared to the standard arm. Only 30 patients survived, 30 patients they have studied, 15 under each arm. And almost 6 patients survived in ECMO arm, and almost 14 patients died in the standard of arm care. So these are the RCTs which has happened over the last 20 years in the AMI cardiogenic shock group. The blue ones are the already completed trials. The important trials are shock, culprit trial, and IBP shock trial. On the right side are the uncompleted trials. Like important thing are ECLS shock trial, Euro shock trial for ECMO, danger shock trial for Impella, and recovery 4 trial for Impella. ECMO CS is a negative trial. There is no difference in the mortality. But the important caveat here is almost 40% of the non-immediate ECMO patients, they ultimately went on to the ECMO support, which may influence the outcome. So these are all the registry data which I would like to show. By following the best practice protocols, it can improve the survival from 50% to 70%. This is a paper published in TCT where they have shown that by practicing the best protocols, it can improve the outcome. In the recover 3 also, the same thing they have shown. They can improve the outcomes by following the best practice protocols. This is in Japanese registry. Here they have 3 years outcomes with the usage of the Impello, where they have shown the survival rate of around 70%. This is in German Italian registry, 202 patients cardiogenic shock with Impella, where they have shown that the 30-day mortality is significantly lesser if you do a complete revascularization and if you use an Impella before the PCI. And this data is also suggesting that if you use a mechanical venting strategy with an VA ECMO, it has a lower in-hospital mortality, but at the cost of an increased bleeding events. And again, this is in Japanese registry where they have shown that when you combine VA ECMO with IABP, the survival rate is significantly higher. And coming on to the last thing, shock teams. Shock teams, if you employ a shock team, normally what we do, a patient comes to the casualty with an cardiogenic shock. Normally they call upon a interventional cardiologist and he decides the further course of action. But that doesn't improve the outcomes. So you have to employ a shock team in your hospital. Based on these data like Innova group and ITO group, they have shown that with the employment of the shock groups, the survival has significantly increased, especially in the MI population. Again, this is in JACC data where they have shown that the PA catheter usage is significantly higher in the shock teams and the CICU mortality is significantly lesser if you use a shock team approach. And with the help of the PA catheter, if you get a complete assessment of the hemodynamics, the patient will have a more survival benefit, especially with the stage D and E group. And more of hemodynamic monitoring can able to pick up more patients with RV involvement and biventricular involvement, which might be missed in without a proper hemodynamic monitoring. And the importance of timing is also those patients who start them on early MCS, less than 1.25 hours, almost the short survival has increased up to 66%. For those patients who are receiving Impella a bit later, more than 4 hours, the in-hospital mortality is significantly higher. And there is still, we don't have any clear-cut guidelines for the anticoagulant usages in the whenever you put the patients on cardiogenic shock with the MCS. So most of the time, the hazard ratio for bleeding events significantly higher when compared with the thrombotic events. So to advance the field in cardiogenic shock, we must randomize these patients in cardiogenic shock. So any patient present with cardiogenic shock scores C and D referred for PCI. Are we willing to randomize these patients to a standard of arm care or to an IABP with the PCI or to an Impella CP with the PCI without allowing them for a crossover? If we do not randomize, then obviously we are not going to advance in our patient care. So these are the shock trials which are going to change our clinical practice, especially Recover 4 and Danger Shock trial. We are eagerly awaited for the results to see the impact of Impella on the mortality. So without data, you're just another person with an opinion. Thank you.
Thank you, Dr. That was a wonderful presentation on cardiogenic shock, so up to date as if it is 2023 and trials in progress. I'm sure in the next about few years' time, we'll be learning more about cardiogenic shock. Because of a lack of time, we are unable to kind of ask or open these last two presentations for any discussion. In fact, we do thank the presenter for the wonderful presentation. Thank you so much.
Thank you.
We'll go on to the presentation or the plaque to the speaker, please.
Requesting the panelists to give a token of appreciation to our speaker. Meanwhile, a quick announcement for everyone that will be provided accommodation at this hotel. Requested to check out, and you can leave the luggage at the main reception area while doing so. Moving forward, we'll have a debate based on the topic role of heart team in striking a balance between CABG and PCI. The first speaker would be Dr. Deepak Krishnamurthy, Senior Consultant, Interventional Cardiology, Kauery Hospital, Mathur.
Presentation, as there is no introduction to this particular debate, it is worthwhile to recall that, we start debating only after we make the diagnosis of angina as to what it is. It need not be coronary artery disease sometimes. If it is coronary artery disease, then we should be having details of coronary angiogram. In case there is a coronary angiogram in front of you, you would like to know what is the patient profile like and what are the comorbidities like. In other words, just having a vessel disease should not lead on to the decision making. I'm sure with the learned audience we have in front of us, we are all aware of it. And I'm sure this debate will be friendly simply because the introductory topic to the debate itself is a heart team approach. With these remarks, may I request Dr. Deepak to get on with his presentation, please.
Thank you, sir. Good morning, everybody. Welcome you to the Kauery Annual Heart Summit. Very happy to see so many people in the audience on a Sunday. Thank you for taking your time out to attend this conference, this CME, which I hope will bring about more awareness amongst all of us. So I'll be talking about multi-vessel PCI. What are the current bottlenecks? With the previous speakers elegantly covering most of the solutions, technically speaking, chip PCI, what needs to be done, what are all the various options available to us in terms of imaging, in terms of circulatory support, in terms of left main PCI, what needs to be done, in terms of chip PCI, what are all the things possible. We have covered most of the technical aspects. But when I was reading this topic on multi-vessel PCI, current bottlenecks or the current challenges, I realized that, of course, solutions, we have a lot of problems, but the actual bottlenecks are something else. So 2/3 of patients with symptomatic coronary artery disease have multi-vessel disease, more complex, lower success rates, higher complication rates, less complete revascularization. And one important aspect which we always have to remember is that, ironically, higher the ischemic risk in a given patient, higher the ischemia burden in a given patient who requires revascularization, higher will be the bleeding risk. So this is another important aspect. So when we come to complex multi-vessel disease, there is anatomy, calcification, fibrosis, length of the lesion, bifurcations, osteal location, left main location, small vessel disease, diffuse distal disease, aortic calcification, prior cardiac surgery. Among comorbidities, we have age, renal dysfunction, left ventricular dysfunction, heart failure, lung disease, bleeding risk because of GI issues, diabetes, valvular heart disease, peripheral vascular disease, and hemodynamic compromise, which has already been covered in our heart failure sessions, in cardiogenic shock, elevated LVEDP, sepsis. Many ICU patients, excluding the ones who have troponinemia, not really having MI, there are a lot of sepsis patients who land up with acute coronary syndrome. What do we do with them? And many of these overlap in the central area, that is surgical ineligibility, leading on to requirement of complex high-risk multivessel PCI. So the goal is to reduce in-hospital and 30-day mortality, also have a decent intermediate and long-term mortality, and our risks should not exceed surgical risk in a given patient with all these factors. So how do we select patients? Of course, based on safety, efficacy, durability of the intervention, comparability with CABG in terms of completeness, as well as risk level. Intra-op and peri-procedural mortality should not be too different. Compliance with dual antiplatelet therapy is another important bottleneck. The patient may be having other comorbidities, other surgical decisions to be made. Somebody may be having a prostate surgery due, or unrelated gallbladder surgery or malignancy surgery, and we may have to stop dual antiplatelet therapy. We'll have to plan around that. And many patients may not be willing to take a long-term dual antiplatelet therapy, which itself is a significant bottleneck to multivessel PCI. One important thing to remember, and why we need to address multivessel PCI as an important topic in intervention and the bottlenecks, is that as the ischemia risk increases, we see that the mortality benefit also increases. If you see the ischemia burden being less, 1 to 5 to 10%, you see that the intervention is actually counterproductive. You may have more risks, more mortality, so you do not get a good outcome. Whereas when the ischemia burden is more, the survival is better, recovery is better, and there is more benefit in terms of quality of life as well as hard parameters. Technical bottlenecks, complete versus incomplete revascularization. Timing is one crucial bottleneck in stable coronary artery disease, non-ST elevation MI and ST elevation MI. Physiology guided and visually guided PCI. I think we have moved past visually guided PCI for most of our patients. It is physiology guided. Intracoronary imaging. Again, availability of intracoronary imaging may not be there in all the centers. So unless we have intracoronary imaging available, performing high risk multivessel PCI, complex PCI may not be a feasible option. That's another important bottleneck. And again, as I told, bleeding versus ischemia. Technical bottlenecks have already been addressed in previous talks. I'll not go into the details of these. Calcific or balloon uncrossable lesions, where you need rotablation or atherectomy or laser in order to achieve balloon crossability, because unless we cross with a balloon, we cannot stent the lesion. So that is a bottleneck which needs to be addressed with the latest technical know-how. Chronic total occlusion is another important area where variable progress has been made by different centers. At some centers like Japan, where I visited in the past, they have success rates approaching 70–80%. There are some centers where the success rate is as low as 10%. It is not uniform. Every operator, every center, every country, in fact, doesn't have the same CTO success rates as other countries. Diffuse disease, another bugbear for interventionists. Small vessel PCI, whether we need to stent them or just do a drug-eluting balloon. Bifurcation, trifurcation lesions, osteal location, heart failure, and CKD patients. CKD patients are notorious for restenosis. No matter what strategy you use, how much imaging you do, how much physiology you go by, they still come back with a significant amount of restenosis. Heart failure, again, who are the candidates for revascularization, whether we should revascularize or not revascularize. and how to safely do it, restenosis, thrombosis, post-bypass surgery interventions, especially SVG interventions, are all the technical bottlenecks. So we have anatomy, we have comorbidities, and we have equipment. So complex PCI is challenged by the comorbidities and anatomy, and we have equipment which include all the imaging, physiologic assessment. Availability of covered stents is important when you're addressing complex lesions, because if there is a perforation, you need to be able to handle it in the cath lab, because every patient cannot be sent for surgery because they're already surgically high risk. Guide extension catheters, embolic protection devices, and mechanical circulatory support, which one of the previous speakers already addressed. So as Dr. Nagraj Desai was telling, the patient is not just coronary arteries. It is not just a syntax score. We need to have a clinical syntax score where we include left ventricular ejection fraction, we include coronary, we include serum creatinine or creatinine clearance, age. So we arrive at a clinical syntax score. Clinical syntax score is more meaningful because somebody having a high syntax score but a good creatinine clearance, lower age, good LV can be safely handled compared to a lower syntax score but having a renal dysfunction, LV dysfunction, or advanced age. So a clinical syntax score becomes more important. Experience of the operating team and the operator are important. So this is more relevant than just looking at the lesions and complexities. This is because, as we know, major adverse cardiac events at 5 years going by syntax scores, when the score is low, angioplasty and bypass are almost same. When it is intermediate, the gap widens. And when the lesions are very complex with a high syntax score of more than or equal to 33, the gap is wide open, where surgery is definitely better than angioplasty. Freedom trial also showed the same thing, where based on the syntax score, the gap between angioplasty and bypass are very evident. But there is a diminishing mortality gap between PCI and CABG going by the New York State Registry. And when the gap is low, you can use one over the other. Coming to the completeness of revascularization, various definitions have been proposed. All lesions more than 50% was the older definition. But now we go by physiologic assessment, either non-invasively in the form of myocardial perfusion imaging, or you can do a stress MRI and FFR and IFR. Incomplete revascularization in the drug-eluting era. So when there is in the New York State Registry, when they compare complete versus incomplete revascularization, meaning you're putting stents, but leaving behind some ischemia. When you're leaving behind a significant amount of ischemia, addressing only 1 or 2 vessels out of the multiple lesions there is a gap between major adverse cardiac events. Obviously, the one who had residual ischemia will not fare well. So there is a significant difference in outcomes between the two groups. One is overall survival and one is survival free from MI. The FAME trial showed the importance of physiologically assessing lesions. So when FFR guided and angio guided groups were compared for 2-year major adverse cardiovascular events, there was a significant reduction when you assessed physiologically with an FFR. Now, of course, there are studies with IFR which have compared similarly and have found that IFR and FFR can be used interchangeably to assess physiology of a given lesion. So what happens when you do physiologic assessment is that you are able to regroup patients. Previously, what we had termed as triple vessel disease becomes double vessel disease. Sometimes what you have angiographically told as double vessel disease may become triple vessel disease when you assess physiology of borderline lesions. Visually, you are saying triple vessel, but when you do FFR, it may turn out to be a single vessel disease because 2 lesions are not significant. So angio-guided and FFR-guided PCI adverse events in terms of death, MI, target vessel revascularization, and combined endpoints are all definitely better in FFR-guided. So functional syntax score, we spoke about clinical syntax score where we added age, LV function and creatinine clearance. Now we arrive at a functional syntax score where with the syntax score you add FFR, which reclassifies patients. Earlier, what were regarded as low, medium, and high, you see that a significant number become low functional syntax score, and a small number are left with medium and high. So, doing FFR reclassifies our patients from triple vessel to double vessel or the other way, and functionally, the syntax score makes it simpler, and obviously the low functional syntax score can be managed with multi-vessel PCI. So this is, there are multiple trials looking at completeness of revascularization in ACS. Non-ST elevation MI is different from ST elevation MI. In ST elevation MI, when the patient is hemodynamically stable, you have to revascularize completely, going by the complete trial. Either during the same admission, you do the culprit artery, give a gap of 2 days, do the other 2 arteries or other 1 artery which has a lesion, or stage it after 3 to 4 weeks. But in ST elevation MI, if the patient presents with cardiogenic shock, it is very clear that you have to only do the culprit vessel and not stage immediately or in the 3 to 4 weeks. Give time. The patient has to first survive. The patient has to go home. We have to reassess after a significant point whether we need to do something and then bring back. Otherwise, the chances of death, chances of renal failure, need for dialysis, not being able to send the patient home are very common. So in ST elevation MI, no shock, either stage plasty in the same admission or subsequent admission. With shock, only culprit vessel. In non-ST elevation MI, it is different. You can do complete revascularization in one go. If you think the lesions are simple enough, the contrast load is not very big, renal function is okay, LV function is okay, the patient is able to tolerate, or you can stage it either way. Coming to the algorithm, this is a simplified algorithm based on all the revascularization trials. If you have multi-vessel disease, stable coronary artery disease or NSTMI, do physiology to reclassify whether it is really multi-vessel or double vessel. Consider single stage complete revascularization. In ST elevation MI, if stable, role of physiology is not very clear here, because when there is acute MI, LV dysfunction, your functional studies of FFR and IFR can be false negative or false positive because of the elevated LV EDP. If the patient is not stable, do only culprit PCI. If the patient is stable, go for a single or multi-stage PCI. Coming to the bleeding versus ischemia risk, another important bottleneck. So you have 4 quadrants here. You have high bleeding risk, low ischemic risk, which you tackle with a shorter duration of DAPT because ischemia risk is not high. You have to mainly handle the bleeding risk. You have the high ischemia, high bleeding risk. You have to prioritize bleeding avoidance by minimizing residual ischemic risk. This is a difficult subset. Sometimes you may have to take help from your other colleagues from gastroenterology, urology, in order to achieve hemostasis with other bleeders and other bleeding points, and manage ischemia as well. Low ischemia, low bleeding risk, of course, you can manage as you want. High ischemia risk and low bleeding risk, consider prolonged DAPT more than 12 years. So to quote Jean Kim, any improvements made anywhere in the system besides the bottleneck are an illusion. So we have to address these bottlenecks in order to achieve major improvements and progress forward. Thank you.
Thank you, Dr. Deepak, for that nice presentation, giving an overview of multi-vessel PCI. Let's listen to the other speaker coming up.
Thank you.
I request the panelists to give a token of appreciation to Dr. Deepak.
Okay. Yeah. Thank you, Dr. Deepak.
Since we are already connected to the international speaker, who is the case speaker to welcome, putting this debate on hold for a while and resume it later. I'll be introducing our international speaker. We'll be having a virtual session with him. Professor Dr. Alan Trippier, interventional cardiologist, professor of medicine, and director of cardiology, University of Florence Charles Nicole Hospital, France. He is widely recognized for having developed breakthrough technologies like balloon aortic valvuloplasty in 1982 and TAVI in 2002. Welcome. sir.
Hello.
Can you please share the screen? Can you hear us? Can you hear us? Sir? Good morning, sir. This is Dr. Swati. Dr. Alan Trippier, sir. Can you hear us? Welcome, sir.
I cannot have my slides.
Dr. Alan. Start. So you cannot hear and you can talk.
I'm sorry, I cannot hear you and I cannot get my slides.
We can hear you now. Can you someone hear us? We can start using our next up, we talk about Abhiram, senior consultant, cardiothoracic surgeon, family and He is a highly experienced surgeon with over 32 years of experience.
My slides are not seen.
Good morning or good afternoon. At the Stroke Festival. Let me first thank the organizers for giving me an opportunity to be part of this academic interaction. And also congratulate the Kauery management for the year let me call me one back. How the cardiology speakers. We had talked about PCA versus CABG was very easy because it's a scientific analysis of public data and answer. Question probably was how surgeons feel data available. It's a very highly subjective response. So I am going to talk to you based on my 35 years of experience in this field. And I am generally known to be talking very frank, totally frank. I may refer you further. No intentional offense meant, but I have to be genuine. So I crave your pardon. I am like Abhimanyu on the 13th day of Mahabharata, with 10 Kauravas speaking and one Abhimanyu here fighting against it. I will do my best. Now, why did you ask this question first of all? Why should they ask what the surgeon feels about multivessel PCI growing? The question was asked because there is a background to it. When CABG came into a regular practice in 1960s, up to nearly 2000, the coronary surgeons were the uncrowned monarch in the treatment of chronic ischemic heart disease. There was only side players in the form of some interventionals. But the table turned in 2000. Now it has gone to such an extent that if you see a coronary angiogram report, they would not even mention advised CABG as though CABG is a dirty word. They will simply say revascularization, as though the word CABG does not exist. It has gone to such an extent. So what do you feel then? The first feeling that you have is the sense of being burgled. Your home has been burgled. You feel anxious, unsure, and uncertain of what holds in future. And there is a sense of dismay. I don't know how many of you have seen the angiogram report. I have seen plenty. Recommended PCI to LAD versus CABG with graft to LAD, D1, D2, D2, everything. This is very common I have come across.
Yes,
I don't understand the logic
hello.
behind.
Good morning. I'm sorry because I can't.
But the worst was the 2021 ACC
But my slides
guideline
are not going through.
downgrading CABG from class 1 to class 2B for chronic stable heart disease based on a single trial. Because they made a decision on that panel that only last 10-year trials we will take into consideration.
Yes,
They
but
discounted all the positive points from the previous 30-year studies. And they downgraded CABG from class 1 to 2B.
Properly.
What else will you feel except
I am absolutely sorry for that.
disappointment and sadness? And then there's a sense of
Can
anger.
you try to check that or?
This is a study by an independent non-profit organization, Lown Institute.
Do you want me
It says US
to
hospitals
share my
performed
screen?
over 229,000 unnecessary coronary stents in 2 years' time.
I
And
don't
it has
know how
cost the
to do
Medicare
that because
$800
it's
billion
very heavy.
per year.
So,
Do you feel happy about it?
um,
No. Ultimately, it is a sense of helplessness because
okay, fine. Thank you.
cardiologists are not at fault.
Thank you.
It is the industry which is promoting it because Lima is available for 0 rupees. Radiolatory is available for 0 rupees. Veins are available for 0 rupees. No industry is marketing it. Whereas stents is a multi-billion dollar industry and the market forces decide what you ultimately get. They talk a lot about this hard team approach, but I don't know where it exists except in paper. A team is not a group of people who work together. A team is a group of people who trust each other. This is an utopian dream, a non-existent myth. I'll tell you why. When a patient comes for chronic stable ischemic heart disease symptom, I've seen many, because it's all adjacent rooms, I've heard. I'll not translate it because I work in Tamil Nadu. But anyway, it boils down to something like this. You see, we get same angiogram, 10 or 15 minutes you are on the table, we'll just put 2-3 stents, tomorrow you can go home. Or else, we'll crack open your chest, we'll make a big slash in your leg, take all the veins, and we can do 3-4 bypass. What do you prefer? If that question is put to me, am I a fool to say I will go for CABG? No, I will not. But is this the team approach? That is not hard team approach. Hard team approach means you're going to tell them about what is your comorbidities, what is the status of your blood vessels, what is your long-term outlook, what is your immediate risk. These things are not discussed. And one last slide about the sense, I also feel happy. It's a mixed feeling. Like many of these CHIP patients that they were talking today, when a 70-year-old patient comes, multiple comorbidities, ischemia-driven heart failure, is daily complaining of chest pain, he is loaded with antiplatelets, his creatinine is 4, and you want to give him some relief, I always rush to my cardiologist who can do 1 or 2 stents and relieve him from his malady. So there is also a sense of happiness when such a situation arises. There are multiple trials. I'm not going to go into all these trials, but I want to highlight some points. From 1990 to 2016, 111 trials have been conducted, comparing multivessel PCI with CABG. And don't miss the point, 79% of them are private industry funded, and only 7 by non-profit funding. There are a lot of controversies in recruitments and interpretation of data. Everyone knows what happened in public about the Excel trial. I don't have to talk much about it. And there is a big difference in results between registry and RCT. So I'm not going into those details because this is not the forum meant for that, because there are a lot of general practitioners also. I'm not going into all details. But I just want to highlight on some very important, this is an important paper which appeared in New England Journal of Medicine in January 2022. It's an editorial on the fractional flow reserve versus angiography for multivessel evaluation FAME-3 trial, where patients over 65 years with just 29% were diabetic. This does not represent the type of patients that we treat. I operate on about 65 to 70% of my patients are diabetics. And majority of patients are over 50% EF. 1/3 of my patients are in the 30-35 EF range. And they have compared 1-year occurrence of all-cause death, MI, stroke, and repeat revascularization. And they have tried to find out a non-inferiority margin. And I forgot to mention all those trials, 111 trials were all non-inferiority trials. They were not superiority trials. Even that non-inferiority margin has not been attained. And the last word on that paper that I presented, the FAME3 trial bolsters the role of CABG as the benchmark for patients with multivessel coronary artery disease. However, a multidisciplinary approach and shared decision-making remain fundamental to the management of multivessel coronary artery disease in our daily practice. Because of that downgrading of level of evidence and recommendation, in Annals of Thoracic Surgery 2023, they published this article. The ischemia trial is a 5,000 patients trial. This is a large study based on more than 100,000 patients, where they have compared 51,000 CABG patients with 52,000 PCI, multivessel PCI patients. And the conclusion is contemporary real-world data from Medicare patients with multivessel disease reveals that CABG outcomes were superior to PCI, providing important longitudinal data to guide patient care and policy development. And that is another dimension I'm going to talk about. I think the speaker has, I don't know, is here or is already left. Now we can do LED stenting. If later on it develops, we can think of CABG. This is a very common way of dialogue I see between the cardiologist and the patient. This is not correct. Doing a PCI and then subjecting to a CABG at a later date is not an easy option because the previous PCI increases mortality and morbidity of a subsequent CABG. This is a paper in the Annals of Thoracic Surgery in 2012.
Yeah, I think it's working now, yeah? Can you tell me when I have to start? Huh? Just give me the green light.
And that's in 2015 Annals of
Thank you very much.
Surgery.
Thank you.
There is a meta-analysis of about 15,000 patients who had CABG after a previous PCI, with 85,000 patients who had a primary CABG. And they found out that patients undergoing CABG after prior percutaneous therapy have a higher incidence of myocardial infarction and mortality in the postoperative period. So, what is the reason why all this happens? Because a previous PCI is not an innocuous intervention. It rapes the vascular biology. It increases the inflammatory cascade in the entire coronary tree. It becomes a prothrombotic battlefield. It does not restrict these pathological changes only to the stented segment. I have operated on many patients after a previous PCI. The distal arteries are all inflamed, thick-walled, and their intima is not as shiny as you would get in a primary PCI, well, primary CABG. So these things have not been looked into except by a very few papers. What is the reason? This is a Christological section. Of course, it has gone to the, which shows that a stented segment causes diffuse inflammatory changes in the entire coronary tree. Even in redos, even I myself have submitted some of my patients who come for a redo intervention to PCI. But I'm surprised when I read this paper, which appeared in JTCVS in 2022, that PCI has a better operative outcome, but repeat surgical revascularization can outperform PCI with regard to long-term mortality and repeat revascularization. We are always talking about long-term results. The surgeon talks about 20-year results. Our long-term definition is 20 years. The cardiology definition of long-term is 2 years. So it's up to you to make a decision. This is a triple vessel stenting done about 3 months back. And he came back in heart failure. He had an ejection fraction of 60% when they did a triple vessel stenting. And now his ejection fraction is 25%. And he has got extensive scarring. This is a patient with a bifurcation stenting. You can see the, I don't know why it's not playing, sorry. See, after 3 months, some of them, they go off. Initial results are excellent. I am terribly impressed with the initial results of PCI. And I am a great fan of PCI in an acute setting. But in a chronic stable angina, Should we overdo it? That is the question. And this is a new problem that we are facing now, especially with this low budget problems that we are meeting with. They do a lot of stenting in very peripheral centers with reuse of material. This is a case of a post-stenting aneurysm. And we have to deal with it. And it's a very... So how do we react to this? One is make surgery less invasive, compromise on completeness of revascularization, no long-term results for this, and converting a life-saving operation into a cosmetic operation. And there is also a hybrid approach, which I don't know, which is probably a sharing of spoils. I don't know. I have my own doubts about it. But it is very important to remember, decisions are more important than incisions. If you want to make an incision by 5 centimeters smaller, are you going to achieve really something great? I don't know. I know Adil is there. He's going to fight with me on that. But my mean is a very balanced approach. I'm not going to restrict myself only to the next react to the situation number. Direct reaction is make surgery benefit longer. We have to strive, educate the population about the long-term results of CABG, give multiple arterial graft. Nobody can compete with the results of a multiple arterial grafting and talk about 20-year results. And the third is a recent one. There is a new breed of what is called as interventional cardiac surgeons germinating. I don't know whether it is correct or not correct. Maybe it is correct if the same person can do both. And if he can, without bias, if he can make a decision, I think that will be the correct thing. But then financial incentives will definitely come into play. We have to wait and see. But it's also another approach to this problem of assault. So when to recommend, in my opinion, PCI in multivessel disease? Definitely in senile moribund patients, when they have got a limited life expectancy, when they have prohibitive surgical risk, or for a subsequent safe CABG. And of course, in low risk patients, because the syntax score is there. And lastly, this is a very important point, strong person. There are a lot of patients who don't like to have their chest cracked open. Not only in Korea, even in India. So when that is absolutely there is no fight on that. If the patient prefers to have a PCI, I think they have to go with the PCI. I started with the burglary, but am I saying burglars are harmful? No, not with this, what happened a few months back. Those 10 burglars only saved 42 precious lives in the Silkyara tunnel. So similarly, is PCI harmful? No, that is not what I am going to say. But what I am trying to say is, in acute coronary syndrome, save the patient by PCI by the cardiologist. But in chronic stable angina, save the patient from the cardiologist. That is all I want to convey. This man started the debate. It is continuing for the last 40 years. But unfortunately, we tend to forget. We are trying to find a mechanical solution to a metabolic problem. So I am waiting for a day when what happened to GJ Vagatomy when we were trainees
fine.
40 years back in
Do you
general
see my
surgery.
slides?
With the advent of H2 blockers, proton pump
Okay, fine. So
inhibitors,
you
and
just, I wait, I am
Helicobacter
here.
pylori
Okay,
treatment.
no problem.
One day we
Thank
will
you.
come out with a pill
Thank you, Nirmal.
that
Thank
will
you.
kill this debate, and we may become jobless, but the humanity will win. Thank you very much for your patient hearing.
Thank you for that wonderful overview, personal as well as general, scientific as well as emotional, and instructive as well as educative. In fact, I'm sure you as a surgeon would recall, it is the surgeons who took along the cardiologist to do the PCI in the theaters. That's how the story of PCS started. And Granjig, I'm sure in several lectures has mentioned, it is a surgeon that he was grateful to. When we started our career in Bangalore City nearly 42 years ago, the surgeon sat with us in the cath lab suite, making sure that we are successful. They were waiting in the theaters, I'm sure, waiting for things to go on correctly in the cath lab so that no emergencies occur. If they are occurring, they are taken care of by the surgeons. That was the bonhomie between the surgeon and cardiologist at that time. And of course, even now it is there in several institutions, and I'm sure the systems in place will care for the patient better. And indeed, if we are committed to the systems, there is nothing better than that. With the future being as it is, I'm sure we will be discussing more and more about disappearance of CABGs and angioplasties with the introduction of the magic pill. If you have one, please share it with me. Thank you so much. And we'll go to the next.
Thank you.
Next presentation. Yeah.
So we have again got connected with Dr. Alan Grippier, so we'll be starting with that.
Oh, okay. Whatever you people say. Okay, good.
Hello, my
Hello,
friends.
doctor.
Do you hear me?
Yes, sir, we can hear you. You can
Yes,
start
fine.
with your presentation, sir.
Okay, thank you very much. So it's a great pleasure for me to be attending this beautiful annual Heart Summit in Kauery, and I have been kindly asked to describe my passion and journey towards TAVI, and this is what I am trying to do. So you have on the slides here, if you can see my slide, the first case performed in April 16, 2002. And, TAVI was highly celebrated everywhere in the world in 2002. And in May, we had a wonderful ceremony for the celebration of this first TAVI case in Rouen with 600 participants coming from the whole world, showing the big interest of the medical community for this breakthrough technology. So, I was coming back from United States, and I was working with Dr. Swan and Gantz at Cedars-Sinai Medical Center in Los Angeles. And I was very open to detect unmet clinical need. And my attention was focused on the development of technical innovation in the field of acquired valvular disease. So I did two things. I developed first aortic balloon valvuloplasty in 85, with the first publication in the Lancet in 86. It was a very big thing. And then I moved to the treatment of aortic stenosis by transcatheter aortic valve implantation in 2002. These two innovations are clearly linked. It was to provide a life-saving option for patients with symptomatic aortic stenosis and declined for surgical valve replacement. And as you know, probably in the 2000s, almost more than 1/3 of the patients were not operated on for different reasons, mainly because of very high surgical risk, and the mortality rate in this non-operated patient was 80% at 2 years. And when I started being interested in this problem in the 80s, surgery was declined in all patients older than 70 years of age. So I was very much concerned by that, and I attempted to solve the major unmet clinical need. So as I said, we started in 85 with balloon aortic valvuloplasty, and this technique was received very highly all over the world, with tens of thousands of cases performed and hundreds of publications on this topic of balloon aortic valvuloplasty. It was a great thing, but unfortunately, it appeared that there was an acceptable limitation with early restenosis at 1 year. So came the idea of implanting a valve at the same time that we were doing balloon aortic valvuloplasty. So in 90, I said in meetings in Rouen that I wanted to implant a valve prosthesis within the diseased calcific native valve on the beating heart using regular percutaneous catheter-based technique and local anesthesia. I said local anesthesia because general anesthesia was one of the great causes for not referring the patient to open heart surgery. So what were the cardiac surgeon's opinion about this project of TAVI? It was considered totally unrealistic with major technical issue to make a valve, definitely impossible to open a stent within the calcific aortic valve. And if we could do that, the results would be very, very bad, very insufficient. This would lead to unavoidable life-threatening complications that are listed here, as you can see here, and it would never be approved by the FDA. And they said that surgery was covered 100% of the need, which was not true, that there was no indications for catheter-based technique for treating aortic stenosis. And in summary, it was the most stupid project ever heard, that the companies had to forget it. So the next step consisted for me to check these statements. In 94, we did something very important. We validated the balloon expandable valvular stenting in human by a landmark autopsy study. Without this autopsy study, we won't be there today. First of all, we could prove on 12 human models of aortic stenosis, fresh cadaver of patients who died of aortic stenosis, that a stent could be opened in all cases, whatever the amount of calcium on the valve. You can see here a stent. This is a Palmas peripheral stent, and you see that the stent can be opened circular without rupturing the annulus without any problem. And also, we could confirm that there was enough room to implant a stent within the aortic stenosis. If the stent was 17 millimeter in length, we are not reaching the coronary arteries, and we are not destroying the mitral valve insertion in opposition to the surgical statement. So I did some drawings to take a European patent showing a possible stented valve, aortic valve, and we made a model of stented valve in Rouen with our cardiac surgeon. You can see here a stent with a three-leaflet valve inside. And when this valve was crimped over a balloon dilatation catheter, the diameter was only 9 millimeter. And it was to say that it was probably possible in the majority of patients to go through the femoral artery to reach the aortic valve retrogradely. So during 5 years, I have been looking for an industry partner, and the project was consistently rejected because the cardiac surgeons were the experts, and they said that it was absolutely impossible to do that. Fortunately, in 1999, I could create a startup with Martin Leon, a very famous, renowned cardiologist in USA, and 2 engineers from Johnson & Johnson. And with these people, we were able to build this tricuspid polymeric valve, as you can see here, a stainless steel stent and a polymeric valve. Then we moved to a pericardial valve, a horse pericardium valve. The stent was 23 millimeter, a unique size of 23 millimeter. So there were a lot of bench tests in the company who made it in Israel, in a small company in Israel. And you can see that the valve was working very well with longevity more than 5 years. And we did a very important, extensive in vivo testing on the animal model, on the sheep model, with my colleague Hélène Elchaninov in Paris. We implanted more than 100 valves of that kind in the sheep, and we could demonstrate that it was feasible, to have, after 5 months, a perfect opening and closure of this valve in the sheep. So at that time, it was in 2002, we were almost ready to move to human implantation. So actually, sorry for that. Actually, we moved from dream to reality on April 16th of 2002 in Rouen, where we did the first in-man case. This was a very incredible case in a dying patient, very young, 57-year-old, in cardiogenic shock, with an ejection fraction down to 12% only. He had a dilated cardiomyopathy. He had multiple comorbidities, and he had no femoral artery available because he had 2 bypasses occluded. He came with a leg ischemia, and he had a floating thrombus in the left ventricle. So, this patient had almost all the contraindications of TAVI today. The femoral artery is being occluded. The only possible solution was to implant this first valve using the transseptal approach. So you can see here the case, we came from a femoral vein, crossing the septum after dilating the interatrial septum with a 1 centimeter balloon, turning into the apex of the left ventricle around this thrombus was there, and then reaching the aortic valve. So it was very dense, in the cath lab at the time of valve implantation. You can see here the gadwar, which was exiting through the contralateral femoral artery, and we reached the valve here in the middle of the calcium. We could deliver the valve, and the result was absolutely spectacular, with the disappearance of all aortoventricular gradient, a rise of the aortic pressure to more than 100 millimeter of mercury, and I could stop the vasopressive drugs. And you can see the patients here immediately after the procedure, and 1 week later, he was totally well and able to walk in the health of the hospital. It was absolutely fantastic. And the publication of this case in circulation in January '86 had a bomb effect on the medical community. You can see here the valve of this patient before the procedure of TAVI. It was a bicuspid valve, very much calcified, as you can see here, and the valve area was only 0.65 square centimeter. And you can see here the transesophageal echo after TAVI with a valve area of 1.6 square centimeter. It was absolutely moving, to see for the first time a valve implanted in a human being, opening and closing normally. And also the CT scan demonstrated that we were right in our anatomical observations, showing that the stent was not reaching the coronary arteries and not crushing the septum with a His bundle, and the mitral valve was totally preserved. So in between 2002 and 2005, we were allowed by the French Health Authority to start a first series of TAVI on a very difficult condition, drastic condition, because the surgeons, cardiac surgeons, were at the head of the French Health Authority. So we had to deal with all inoperable patients, functional class 4. Imminent death means that the patients were supposed to die before 2 weeks if we did nothing. And they asked us to use a transeptal approach. That was the approach used for the first patient. But actually, at the end of the series, we were able to do some retrograde transfemoral approach. So it was very challenging because we had to demonstrate the potential benefit of this new technology on a subset of critically ill patients with major life-threatening comorbidities. So actually, we did a transeptal approach in 33 with 85% of success. And we could do the retrograde transfemoral approach in the last 7 patients, but we had 3 failures because you should understand that we didn't have any delivery system. And also we had a single size valve of 23 millimeter. The results were published in the JACC, and it was also something very important for the future of TAVI. So this is the valve that we are using. You can see here again, the single size 23 millimeter. And we were crimping the valve over a pneumat balloon. There was no delivery system. The valve was just at the end of a pneumat balloon. And we were going through the femoral vein, exiting the gadwars to the contralateral femoral artery to have a very solid road, solid way, to go and reach the valve. And this is what we were doing. And from this series of patients, we had 50% who did survive more than 6 months with no symptoms and returned to normal life. And 5 patients survived more than 1 year, 5 years, with no change in left ventricular function. I just would like to give you 2 examples of these unbelievable results of TAVI, who had a major impact on the early recognition of the procedure. You can see here the patient's number 3. This patient was dying. She was 83-year-old in cardiogenic shock with multiple comorbidities. He had a recent anterior myocardial infarction. She came absolutely dying, and you can see the patient 6 months later, back home, doing perfectly well. And the patient was able to travel to Washington, D.C. for attending the TCT meeting and giving a testimony in front of 2,000 stunned cardiologists and cardiac surgeons, and she has played a very important role in the TAVI recognition. You can see the patients 2 years later and 6.5 years later with unchanged hemodynamic results and return absolutely to normal life. I show you also this patient. She was number 10, an 85-year-old woman who came to us in the same kind of critical clinical condition with an associated mitral stenosis, impeding us to use the transeptal route. For I got the clearance from the health authority, to for the first time try to use a retrograde transfemoral approach. We did that under local anesthesia sedation with no TE or whatsoever. And the procedure was very short. And you can see here the very first vision of a valve implanted retrogradely with this result, which was absolutely amazing. And for us, it was a very important thing, because it was so simple, to place the valve in and to get this beautiful result. And you can see here the same patients 5 years later in Morocco, with unchanged hemodynamic results. So my conviction at that time that a revolution in medicine was underway. Then TAVI took its flight in the world, and I have been proctoring a very important interventional cardiologists like Martin Leon, Bill O'Neill, John Webb, Colombo in Italy, and Patrick Seris in Rotterdam, and doing the transeptal approach on compassionate basis. And in 2005, the 100 TAVI mark was passed. So this was the number of patients done in 2005 in the world. In 2004, Edwards Life Sciences finally acquired our startup company, Percutaneous Valve Technology, and they moved from my valve, my stented valve, 23 millimeter equine pericardium, to the Edward Sapien valve with a larger size, 26 millimeter, which was very important, as you can understand. And they use a treated bovine pericardium tricuspid valve. It was actually a Carpentier-Edwards valve inserted inside a stent, and they increased a little the coverage of the stent. And this valve was going through a 22 French for the 23 millimeter valve and 24 French for the 26 size. So it was conceived for implantation via the retrograde transfemoral approach. And John Webb has been, evaluating this retrograde approach with a new delivery system that we call the Retroflex catheter, which was steerable, so very convenient. And then they moved to the Retroflex 3 in 2006, adding a nose cone at the end of the catheter, which was facilitating the crossing of the valve. And with this device, were done a lot of European registries, including the European source registries with more than 1,000 patients. It was very, very significant, again, for the acceptance of TAVI, and also the first pivotal randomized partner US trial in 2009. So at that time, when we were doing the transfemoral approach, we needed to do a femoral cut down because of the size of the sheath, and it was a relatively long procedure, 2 hours. The patients in general were discharged after 8 to 10 days. We had the cardiac surgeons with us in the room to do this kind of transfemoral approach because we had to open the groin and close the femoral artery at the end. So it was a big thing. Then in 2005, there was an alternative approach coming up, with a transapical access, also developed by Edwards with another delivery system. It was a mini-invasive surgical approach. And I was in the room with Michael Mack and Frederick Moore for doing the first transapical TAVI in Leipzig in 2005. And they say that it was like the devil entering the OR, because for the first time, the surgeons were able to use a transcatheter valve. And with these two methods, transapical and transfemoral, almost all TAVI candidates could be treated. In 2005, there was a launch of a concurrent device, a self-expanding core valve, which became the Medtronic core valve, as you know, with a very, very strong marketing power. And it came immediately in 21 France. And so this was very convincing for many, many operators. And even though the results were not as good as the balloon expandable valve, the size of the sheath was really crucial to use this technology. It was developed by Jacques Seguin, a cardiac surgeon in France, and very well supported by Ebrard Gruber and Jean-Claude Laborde that probably came to your center. And it was the start of a fair and ongoing competition between the two devices. And this competition has been very helpful, to see TAVI moving all over the world. The worldwide expansion was really important due to this competition between the two devices. So where are you 20 years later? I know it's absolutely unbelievable. We are now reaching almost 3 million TAVI cases in the world, in more than 80 countries, including, of course, India, and I am very proud of that. I have a special love to India. And the TAVI market actually exceeds the surgical market in many countries. And we are expecting a growth of 40% per year. You can see that in 2003, in France, we had 20,000 cases done, 80,000 in United States, and in a single year, 233, more than 220,000 patients were treated by TAVI, which is very impressive. In 2019, it was the apotheosis of TAVI with the results of Partner 3. I will say you a word about that. But FDA approved TAVI for all low-risk patients above the age of 65 years with the two devices, SAPIEN 3 and Evolute. And in Europe, the age limit was 75 years, but between 65 and 75, the patients can decide whether he wants or not to have TAVI instead of surgery. So we are reaching a new paradigm. TAVI was conceived for patients who are not candidate for surgery. And in 2024, surgery is indicated in patients who are not optimal candidates for TAVI. So it's absolutely extraordinary. So the reason of success are double cause, improved technology and skill, and large body of scientific evidence. So very rapidly, I would like to show you what happened. First of all, there was a better team experience that participated in the widening of the indications we have in the world, but also, better patient screening. And this was a very important move, with the use of MSCT for assessing the patient situation before TAVI. And it was not done immediately, it came only 5 or 6 years after the first case. And so now it's possible, to assess the vascular approach, and the anatomy and the valve sizing is done also by CT scan. So this has been a fantastic tool, and thanks for the industry, which has been working on our side. And also, and mainly, the continuous improvement of valve and delivery system, and leading to a decreased sheath size, additional valve size, to improve the coverage of the aortic annulus, improve sealing and positioning with new delivery system. And you know what happened, every 4 years, there was a new generation of the Edwards valve with a decreased sheath size from the SAPIEN XT to the SAPIEN 3 with 4 sizes. And we had a decreased sheath size from 24 French to 14 French. So you can understand that this was absolutely important. The external skirt on the SAPIEN 3 was also something extremely important to limit the risk of paravalvular regurgitation. And the same kind of progresses were made by Medtronic, decreasing the sheath size, increasing the number of size used. And this was a very important progress. During that time, many emerging TAVI systems came out, but very few finally succeeded to human implantation. Grossly in Europe and United States, we had the Symetis, the Portico from Abbott, Symetis from Boston Scientific, and the Lotus from Boston Scientific. The Lotus disappeared after a few years, but two devices offering, I must say, insufficient results with this first generation device. And came also this recent balloon expandable valve from India. And I want to say how beautiful it is. And I consider that this valve is probably one of the best on the market today for doing TAVI, offering a very large number of cells, multiple sizes with half sizes from 20 to 32 millimeter, which is absolutely important for especially in the United States and Europe. And for optimal annulus coverage, this is with a beautiful skirt. And also coming, with 14 French introducer for all valve sizes, which is also an advantage, a steerable delivery system. The valve come pre-crimped over the balloon before use in opposition to the balloon expandable Edwards. And so this is something absolutely great. And this valve allow to obtain the lower rate of paravalvular leak. So it was not the end of the story because Edwards continued, to improve the device with the Sapien 3 Ultra that you know very well, with improved the length of the skirt, external skirt, and to the Sapien Resilia, which is a special valve with a special anti-calcium coverage of the leaflets for improving the long-term durability. So this valve, and especially the Sapien 3 Ultra, is currently used everywhere in Europe and United States. And on the Medtronic side, they moved to Evolute R and Evolute Pro. They added an external skirt eventually. This was very important and make a big difference in the result. And you see here the Evolute Pro, with a lower delivery profile and change in the morphology of the frame. So very important improvements. And on the Boston Scientific and Abbott side, they also improved their device, making the accurate Neo 2, with an external skirt and also very large cells. This is a very interesting device, which is supraannular insertion, and the port and Abbott developed the Navitor again with an external skirt that changed everything, making the technique easier, and also it's an intra-annular insertions like the Edwards, so two other devices that are moving up actually. And on the Indian size, they came with octa-core, and this is a very unbelievable piece of jewelry. This is not a valve, this is something extraordinary, with an octagonal shape of the frame, making the precise and predictive deployment, reducing the foreshortening by 50%. So when you implant the valve, it's extremely simple. Again, with multiple sizes and some regional system for precise commissural alignment. So this is really a masterpiece, and I think that the future of this octa-core is very great. So as a consequence of advanced technology, the transfemoral approach could be used in the vast majority of patients, with some other possibility of when the femoral arteries are blocked, for example. But the transfemoral approach makes the procedure very simple, faster, and safer. Can be done in more than 95% of cases today. So this is a great advance. And also we developed in our side the minimalist transfemoral approach, making the procedure even simpler, faster, limiting the number of people in the room. And the patients can now be discharged before 3 days after the procedure in more than 75% of the cases. So this technique has been very criticized at the beginning, the strategy, and especially in in UK and United States, they did consider that unethical, to use local anesthesia, pure percutaneous approach, and so on. But now it's done everywhere in the world. So the reason of success is also based on a large body of scientific evidences, with a particularly challenging pathway, with stage evaluations from critically ill to low-risk patients, which is very unusual to assess, to evaluate a new technology in medicine. So we had multiple national, international registries, starting from 2003, and then a national registry, which are still ongoing everywhere in the world. I show you here the French registry, in 2011, and the France 2 registry that was published in the New England Journal of Medicine in 2012 with 27 ancillary studies. So the registries allowed the physicians, to understand how to use TAVI in their daily practice. And then came match registry, in patients with intermediate risk only, showing the same results on the mortality and after surgery. But the most important milestones were, of course, this evidence-based trial that you know very well, with against versus surgery. In inoperable high and high risk patients 2012, intermediate risk patients in 2016, low risk patients is 2019, with the 3 models of valve on the SAPIEN side, with a non-inferiority or superiority of TAVI on all main endpoints, including mortality rate, short term and long-term reducing the stroke rate, limiting the rehospitalizations, and improving very rapidly the functional status of the patients. And similar scientific pathway were done with the core valve, with similar results. So now, just a word about the future. We have a growing number of patients, and so we'll have a growing number of TAVI. This is absolutely obvious, and increase the number of centers and operators, including the cardiac surgeons. New technological advance, with leading to democratization of TAVI in the world. Scientific registry ongoing in the valve-in-valve side, the bicuspid valve, and so on. And very importantly, randomized trials for new TAVI system, but in new indications, TAVI in moderate AS or TAVI in asymptomatic patients, which should have a considerable impact on the future of TAVI. Also, the general practitioner have to improve their detection of TAVI and take the good TAVI, therapeutic decision, and the decreased TAVI costs that are obviously at the end of the tunnel, it should come with a competition between device and the increased number of patients. So we can be very optimistic about the future of TAVI. So you see, this has been a very long odyssey, 40 years since the first in-man balloon aortic valvuloplasty that we did, the first in-man TAVI case, the CE mark in commercialization of the device in 2007, the multi-center registries, and the 3 rounds of evidence-based trial, leading to finally, at the end of the road, to expansions to all comers. And we have some remaining issues concerning the valve durability, some early valve thrombosis, the use of TAVI in younger patients, which device can be used in first intention in younger population, and with the goal of making possible to access the coronary arteries in the future. Finally, this breakthrough technology also opened a new world in cardiology by stimulating the transcatheter treatment of other valvular disease like tricuspid valve, mitral insufficiency, and structural heart disease. So you see, in 20 years, the initially considered impossible and insane, this technique has known a considerable expansion in the world, leading to, with continuous advances that I have been explaining to you. there was a fantastic partnership with the industry. It was a clear-cut success of translational research that way. And many investigations are underway today to answer the remaining questions that should accelerate the expansion of this technology in the future. That's where we are today. Thank you very much, my friends. Thank you.
Thank you very much, sir. 20 years ago, on April 16th, 2002, the first TAVR procedure was performed by Dr. Krebier and team, which opened new horizons in the treatment of structural valve disease. And the rest we say is history. So we're very privileged to have Dr. Krebier speak at our Kauery Annual Health Summit.
It's
Next
my
up,
pleasure.
thank you, sir. Next up,
Thank you.
we have
Thank you so much.
Thank you, sir. Next up, we have another international speaker from Ecuador, Dr. Diego Igas. Dr. Diego Igas is a consultant invasive electrophysiologist with a subspecialty in artificial cardiac stimulation. Welcome, sir.
Thank you very much. Can you hear me?
Yes, we can, sir. Please proceed.
Okay, thank you. Thank you so much. It is a great pleasure for me to be here. I would like to thank you for inviting me to be here. And at the same time, I'm going to talk about one of my favorite topics in medicine and in electrophysiology. So I'll talk about leadless pacing. It is almost impossible not to think in future when you're talking about leadless pacing. The best way to predict the future is to create it. My disclosures. In the very beginning, we were talking and celebrating about big technologies, and actually they were very big. They were the first pacemakers in the world. And that was like 70 years ago. So with time, we started celebrating something more tiny, smaller devices. And we started 70 years after, we started celebrating that there was small technologies that performed the same procedure, but with very tiny device. So we started in 2013 with this small micro devices, micro pacemakers. And then in very fast, 7 years after, we started developing like more synchronic pacing. In 2020, we started with AB synchrony. After that, we were searching for more advanced technologies, and nowadays we're dreaming with more physiologic technologies in the same area. So today's agenda is to review a little bit about the whole procedure, and then we will go to specific topics. So let's start. This is more or less the procedure. We start with a puncture. It's very similar to what Doctor just talked about. We approach via femoral, but this is vein, not an artery. So we go up and then we start like just going into the right ventricle, and we confirm that we are in the right place before deployment of this micro pacemaker. Then we leave the pacemaker in place, and then we start performing electronics in order to know if it's stable inside the ventricle and in order to know that it's pacing in the proper way. And then after we cut all the control that we have between the device and the delivery system, and then we leave the pacemaker inside already with the capacity of pacing the patient. So this is the micro, how it started. In the very beginning, we had two types of pacemakers. We had one from Medtronic, one from Abbott, and they both perform almost the same thing, but with different delivery systems and with different attachment system. So we had problems with Abbott device that was called NanoStim, and the only one that was in the market since then was Micra from Medtronic. And since then, we have like the very initial study, and we have several studies that have demonstrated efficacy in terms of pacing. So we have capacity to stimulate, to pace the ventricle in a proper way with good sensitivity and good threshold during the time, so we can pace in a proper way. By what not a conventional system? Why not keep doing the way that we were doing for years? Because many times more exposure can lead to many complications. So as we can see here, we have a pocket problems, like for instance, I can have pocket infection, erosion, hematoma, and also related to leads, we can have fractures of the leads, we can have perforation, effusion, tamponade. So everything can lead to a problem once you're using leads. And actually, the databases show us that sometimes we can have big complication and also very frequent complications. So this is what we are trying to avoid. Most of the complications are related to leads, but we also have complications related to pocket and pocket hematoma, erosions, and infections. We have seen that with leadless pacemaker, we can reduce the complications in a big amount, like 63% of the cases can be avoided. And this is a special complication that we need to avoid, that fortunately, it's not so common, but it can be very deadly. It's infection. For instance, here we have, from the very beginning, we started seeing that the complication of infection in this kind of devices was very small in the databases and the series of patients. So many patients need to remove the device because of infection, endocarditis, and even thought they had bacteremia, endocarditis, and also sepsis. They implanted the devices immediately, and we saw that it was not common to have an infection. So when you start thinking on that, then you realize that maybe the 10 times higher cost of a device like a Micra, it's justified because once you have complication of leads, complication of pockets, erosion, endocarditis, then you can compensate actually the whole price of a leadless pacemaker. And that's actually the conclusion that the people from Norway had once they started analyzing the benefit of implanting leadless pacemaker. So why this lower infections rate? We actually don't know, but we have a lot of hypotheses. For instance, the fact that we don't have a pocket, the fact that we don't touch the device, the fact that we don't have leads or something like a bigger area to infection, the early encapsulation, or maybe something related to a turbulent environment where we leave the device. So this is the early encapsulation we have seen in many patients post-mortem. They go to an anatomy analysis post-mortem, and they find that many devices are encapsulated only a few months after the implantations. So current indication, that's easier right now because we have guidelines that talks about a specific leadlets indication. So if we have a difficulty of access, venous access, of a higher risk of device pocket infection or previous inspections or hemodialysis, then we have a class 2A with level B of evidence to indicate this kind of devices. But if we have something related to life expectancy, we can consider and we can discuss, so we can individualize as a class 2 indication according to the ESC 2021 guidelines. So where are we now? What do we have to do now? So the options that we have in the market, it's Micra, BR, AV, Micra 2, AB2, and also this relatively new device that Abbott developed, that it's like the second generation after NanoStim, and it's the only dual chamber pacemaker. So when we talk about pacing, we want something extremely close to what it's normal in the heart, normal in physiology. So they started thinking of that, and they started developing a device that can sense the atrium and pace the ventricle. And the trial Marvel 2 demonstrated that with Micra, we can sense, we can feel the atrium, not in an electrical way, but in a mechanical way. I can feel the atrium and started following the atrium, pacing just the ventricle. And with a high efficacy, they demonstrated that even though they changed it with postural maneuvers, they still had this AV synchrony. But that was not enough. They started implanting devices in the atrium in ships, in animal models. So now we have this trial that it's demonstrating that it is possible to implant a Micra in the atrium, and it's also possible to retrieve the Micra and implant another one in the same place. But Abbott went beyond that and started experimenting in a dual chamber pacemaker, leadless pacemaker. So they published this in 2023, and they have also the approval in CM market and also in FDA. So they started with this device that is the AVEIR dual chamber pacemaker. So the AV synchrony is possible in a high amount of patients. And actually, real pacing of the atrium is possible, as you can see here with one of the patients of the EKG of the patients. So AVEIR, we go to monitor, then we go to implant of the ventricle, then we go to the delivery of the atrium. The mechanism is different from Micra. You just go inside, like going inside, turning around, and then you can synchronize both in order to pace without any lead. But is that enough? We were thinking that not. AV synchrony is not enough in most of the cases, because nowadays we're thinking more on physiologic pacing. But what about second generation of Micra? This improved a lot the longevity of the devices, improve a lot the AV conduction algorithm, and also the delivery system was improved in this kind of patients. And as you can see, the battery longevity went to 16 to 70 years in media. So it's quite nice. And it's better because most of the cases, the only leadless pacemaker that you implant will be the only pacemaker in the life of the patient. So it's enough. But sometimes it's not enough to think on AB synchrony and dual chamber, we're thinking on pacing the conduction system. And this is one concept that started in Latin America, because in Latin America, we have some sort of EKG, objective EKG, to demonstrate synchrony, that it's called Synchromax, developed in Argentina. And we have a lot of evidence related to that you can demonstrate with an index how synchronic the pacing is. So we published in 2021 the first case of leadless pacemaker guided by Synchromax. So the idea was to implant the pacemaker and demonstrate how well the index was. So as you can see, this is some sort of objective index, as you do when you're trying to demonstrate mechanical synchrony. Once you go to speckle tracking or strain in echocardiogram, so you can do almost the same electrical synchrony, an index, objective index, as here. If you have an index very high, above 0.2, then it's not synchronic. And if you have index that improves and goes like this, you can say that it's synchronic, for instance, in this place. So it's all well demonstrated with conventional pacemaker, but we are trying to dream to have this synchronic indexes in leadless pacemaker. So we all know that septal implantation is a routine in Micra and leadless for safety. But if we can map the septum and know where in the septum we can put a more physiologic pacing, then in the future maybe we will be talking more about septal implantation as a routine, but more for synchrony rather than safety. This is our research. These are the first results of our research. We will go to the septum, we map the septum, and we try to explain where it's better to implant the Micra. So this is our results. We have indexes, high indexes in the beginning, and in some areas of the septum, we improve the indexes. So that's interesting because we could be synchronizing with a leadless pacemaker. Some areas are not good to pace, as you can see here, and some areas are like neutral, and some other areas of the septum could be synchronic in order to improve and variate in an improvement the index of pacing. Leadless is running. It's running faster than any other therapy. I was hearing about TAVI and how much it has increased in the last 40 years, where we can see here in Micra and leadless that in 10 years we have improved a lot. 10 years ago, we were celebrating the first implantation of Micra. Now it's worldwide. And it is predicted that in the near future, we'll have like a giant market of leadless, and not only in terms of numbers, but also in terms of the amount of money that this leads to payment of the insurances and stuff. So to take home messages, I need to say that leadless is present on daily practice. Not only that, the indication might become mandatory in specific cases for some patients. And in the future, not very far future, we will be talking about leadless, physiologic leadless. And if that happens, maybe in the future, this would be the only idea of patient. So thank you very much. Stay calm and keep dreaming with leadless physiologic pacing.
Thank you, Dr. Igas, for your presence. Next up, We have Dr. A. Manoharan, Senior Consultant, Cardiology from Kauery Hospital. He'll be the last person of the debate session. So I request the panelists from the previous debate session to please occupy the dais as well. Thank you.
Good afternoon, everybody. The most difficult talk is always a pre-lunch talk, where the audience, the speaker, everybody is very keen to finish and go for lunch. But then pre-flight topic is also equally important, where you have to catch a flight. And more importantly, in a debate, the maximum challenge comes when the previous speaker speaks and you're all, excited, trying to match point for point, slide for slide with the previous speakers. Luckily, because of the interruptions, we got a lot of time to reconcile, recuperate, and come back. So today I am here to kind of strike a balance between my previous two speakers. Previous two speakers are both well known to me and are really team members and, who in fact portray what I want to convey, the concept of a heart team approach. So what we mean by a So what we mean by a heart team approach in the patients with coronary artery disease is, when I put up this thing, many people may get thinking that I'm going off screen or, off topic. So do you find any difference in these two pictures? Probably not, because according to me, this is like this. Unfortunately, we are people in the same family. So there is no point in trying to prove who is better than the other. If you understand this concept, I think the rest of the things become far more easier to discuss and far more scientific in the discussions. So sir mentioned about heart team. So heart team is not something new. It's actually a 10-year-old concept. This appeared in JAC about 10 years back. And the idea behind this heart team was to convey the concept that everybody contributes in decision making. And that is going to be the core of my discussion today. And sir mentioned about, in fact, Dr. Deepak mentioned about when he will consider PCI, and Dr. Raghuram sir mentioned about when he will consider surgery and when they will consider the opposite. I think in a summary of whatever they said, if we can highlight all these points to every patient, I think the job is far easier. In fact, I have picked up from their slides and put these slides in picture. So every patient, if the surgeon and the cardiologist are able to convey this much, I'm not saying you have 1 hour discussion with the family, but at least this much basic things, tell them the advantages, tell them the disadvantages. Similarly, Dr. Deepak and his team, if we were to just enlist this thing to every patient that they discuss for revasculation. Just one single slide covering everything that both the speakers tried to convey to us. If honestly, each one of us covers these two things, we can always go back to what Dr. Raghuram sir concluded, patient preference at the end. But honestly, each and every point in this slide, if we convey to each and every patient, I think we have done a great duty towards the patient and a great duty to our field. And that's what I would like to emphasize repeatedly at the end of this talk of mine. Unfortunately, as sir rightly said, we are always talking about the negative aspects of other while promoting the modality that we prefer. If we accept that don't compare apples and oranges, for people who prefer apples, give them apples, and people who prefer oranges, give them oranges. If you have that mindset, I think life is far easier. And one important treatment I think I always find is, there are a lot of people who come for second opinion. They have gone to a cardiologist who advises stenting, and they have gone to a cardiac surgeon who advises CABG. And some family member is known to you and they come to you for so-called third opinion. I always find it's very interesting that nobody discusses with the patient alternative treatment. Because at the end of this debate, what happens is we convince the patient so much about our modality of treatment, And patient believes that both of these people are marketing their line of treatment so much, he ends up treating himself by so-called non-invasive technologies, which offer really bad results. In fact, Dr. Raghuram sir pointed out that chronic stable angina has been delegated to 2B. In fact, these are therapies which are class 3. Unfortunately, none of us work as a team to highlight the disadvantages of treatments like chelation therapy. All of you people in this audience are aware of chelation therapies in your own city. How many of us as a team try to highlight the inadequacies or the risks involved in chelation therapy when we talk to patients? We are all obsessed with our line of treatment as the best. Unfortunately, we all behave like George Bush. Either you are coming with my line of treatment or you are going out. Unfortunately, we should tell the patient, whether you go with my line of treatment or this line of treatment, you still remain my patient. If this concept, if we develop, it makes a lot of sense that whether they agree to our line of treatment or not, we should accept and understand their mindset rather than being saying, I'm telling you, if you don't want to listen, just walk out of the room. If we were to do that, we will always portray this simple concept. I always tell my patients, it is very important to undergo revascularization. So in my, sir mentioned about one report where they had mentioned CABG PTC option. I never write that option. I write revascularization. Because I personally feel if all of us followed this dictum, that we convince the patient that revascularization is must, and then as a choice later. So if every one of us, every cardiologist in this forum makes this as a dictum, tell the patient that this needs revascularization. In fact, Dr. Deepak alluded to some of the examples where people had triple vessel disease turned out to be double vessel disease. All this is possible. But unfortunately, in our reports, we have the habit of committing PCI to LADs, circumflex and RCA, or CABG with grafts to D1 LAD. Why should you commit? You commit to revascularization first. You convince the patient the importance of revascularization, and then sit down to discuss the choices. In fact, we always say, it is not our colleagues who badmouth us which do more harm. It is our colleagues who remain silent to wrongdoings amongst us that do more harm to us. And that is very important. And that's something I would take the opportunity to use in this forum to highlight, that it is the silence of people which hurts me more than some people bad-mouthing my approach. Sir mentioned about hybrid revascularization, but I'll just go through the disadvantages alone because we all know the advantages. There is no data to support it. Although some of my colleagues have prospectively done 50 patients, 100 patients, but it's a concept worth analyzing. The only challenge in our country is cost, and maybe reimbursement may also be an issue. But as of now, there's no data to suggest its superiority over CABG, although it offers an option for the future. Maybe it may be the best of both worlds in the future. He mentioned about heart team approach and mentioned whether it is a utopian dream. Why can't we take advice from our structural colleagues? Structural colleagues have already evolved a concept of a heart team approach. Why can't we relearn from our structural colleagues and understand how the heart team evolves? And if you look at the whole concept of how the structural teams, sir was mentioning, why people don't agree. Because we don't reward the team. Even you attend an ethics committee meeting, people are paid today. But if you attend a heart team approach, are you paid anytime? If you reward the team, create a psychologically safe atmosphere. It is not about name calling. It is about deciding about the benefit of the patient. If we conduct the heart team discussion to establish the process, invite and allow dissent. We have had discussions where the surgeon has walked out of the room. The cardiologist have walked out of the room. But still, we allow for dissent. We give an option to the patient, to the team members to express. In fact, we have more surgeries cancelled by cardiac anesthetist than anyone from other team. So such things do happen. Be open for unique information. Discuss rather than vote. We are not in an election. We have to discuss. There is no voting system. It's not that the surgeon has the power of veto or the cardiologist has the power of veto. This is a discussion, not a voting session of the United Nations Security Council. But please understand.
Excuse me, sir.
2 minutes. I'll
Two
come.
more slides.
2 more slides, sir.
Okay.
So despite all these things, if you look at teams, it's not that every time the heart team discussion is fulfilled. Very often final decision is different, but at least we discuss. So this is from a structural team. And most importantly, the physician's training of competence is important. I still remember 30 years back, my cardiology teacher used to send all patients of tetralogy phallates for BT shunt, simply because he believed the competence of the surgeons was good enough to that extent. Today, people will get angry if I talk like that. So physicians' core competence ultimately decides. And 2 things before I finish, 2 things. If we were to publish our results online, like it was tried in the UK, I know many of us would avoid doing interventions which make our results look bad. And last but not the least, if we have pay parity, I think most of our debates would decline. Whether I do an intervention or I send the patient for surgery, if I paid equally, maybe it may make a difference. Last slide. 56-year-old male, severe AS, triple vessel disease, left subclavian CTO, bilateral renal arteries. We discussed, we included the vascular surgeon, included the nephrologist, ended up doing a renal stenting followed by a left subclavian stenting. And 2 weeks later, patient underwent a CABG with AVR, Lima, and 3 more grafts. Another example, 67-year-old male, PAD, post-DEB, CVA, coronary artery disease, significant calcium. Same discussion, family full of doctors, neurologists, vascular surgeon, everybody was involved. Vascular surgeon said medical management, and we ended up doing PCA for this patient. Before I conclude, forgive me because both the speakers are very close to me. If I happen to say anything that Deepak didn't agree to, maybe the entire Twitter will troll me. And Dr. Raghuraman, I have to go back to Chennai with him on the same flight. So forgive me because my teacher always used to say, every time you see a patient and assume that patient is your mother, the chance that you'll do a mistake is very unlikely. So I think here it matters a lot. Thank you.
Very interesting. You said that mother, not father. Okay.
So that is because my teacher told so, maybe.
Okay. You're so kind of a copycat. Okay. In fact, all the 3 presentations on the multi-vessel PCI versus CABG were so well balanced, though emotional sometimes. It was well presented to all the audience. I'm sure the audience would have appreciated the limitations of both the technologies as we are learning from the masters just about 2 minutes ago from the international speakers also, how they struggled to establish a procedure of their liking, and they made a life mission. I'm sure Professor Raghuram and my colleagues, Dr. Krishnamurthy, Dr. Deepak, and also Sahil, also all of us would have struggled to create a niche for our lives, mission for our life, and we should not be believing it too much. Beyond a point, we should be open to discussion. Modern education is about relearning, leaving out the bad habits we have learned from our textbooks and from our professors. Fathers are also as important as mothers.
Sorry for that.
May I open this presentations with an opening remark from a surgeon along with me in the chair here, because 2 cardiologists presented their points of view and surgeon powerfully also presented his point of view. May I request Sarj to
Thank you so much, sir. I think it's imperative. Gone are the days, say 25 years ago at the start of our training, Every triple vessel disease will go in for surgery. That was the norm. That is the thought process. I've worked with very extremes of surgeons as well. I've worked with mixed surgeons as well, balanced surgeons. I think what's important to understand is what is best for the patient. We may feel one form of therapy may be the best, another form may not be appropriate. There's enough amount of data to say every therapy has its own advantages, has its own disadvantages. And I think it may take 5 or 10 minutes more, but it's important to educate your patient as well as the decision makers in the patient's family to enable them to help us provide the best for the patient. So I think that is a very key. I think communication with the person who's receiving the treatment and the people who are making the decision is important. If one chooses one over the other, after this has been disclosed and explained, well, that is what modern medical treatment is all about. So I think balance is the key. And going forward, there is a role for everything. Going forward, there is a role both for advances and technology, both helping surgeons as well as cardiologists. So I think it's a win-win for all, especially for the patient.
Thank you. The surgical suites and cath lab suite should be adjacent to each other. Both surgeon and cardiologist should use the same washing area and also to kind of sit for their coffee and snacks so that they can exchange the thoughts better. Because gone are the days where we used to use weekly meetings to discuss and use it as a platform for fellow training and fellows training as it is nowadays. Today, I don't want to comment about it at the moment, at least. Suffice to say here, the bonhomie between the surgeon and cardiologist discussing their issues and the patient care would benefit a lot. Having said that, I take this opportunity to invite Dr. Deepak Krishnamurthy and Dr. Raghuram onto the dais here, sir. Do you have any other questions from the audience, please? If there are any, you could discuss it over lunchtime as we are running out of time. And the presenters, the momentous to presented, please come.
Going on with our session in electrophysiology, I request the next set of chairpersons to come on stage. Dr. Nagamalle Shiva, Director, Heart Failure and Transplant, Aster Hospitals, Bangalore. Dr. Prabhakar P. Koregal, Senior Interventional Cardiologist from Fortis.
Cardiac electrophysiologist, cardiac scientist.
Yeah, Deepak, you can start in the interest of time. We'll save the time on the introduction. So.
Love for the slides to come up. Thank you. At the outset, thank you for this opportunity to present before you. I think it's an important topic amongst all that we are discussed so far today and according to this session. The objectives of my talk are to discuss the current state of AF ablation. What is the long-term follow-up for rate control strategy comparisons, data on early ablation, role of energy sources for ablation, modification of the natural history that someone has once atrial fibrillation sets in, and finally, the long-term outcomes of the same. The rhythm management in AF and underlying progression of atrial cardiomyopathy, including remodeling of the atrium itself, are tightly intertwined. There is need for rhythm control in AF because mainly, if you look at long-term studies, there is a higher risk of stroke or systemic embolism in these patients. The hazard ratio is 1.38, even in the presence of anticoagulation. Similarly, mortality is also higher in these patients when followed up long-term. The hazard ratio there is 1.2. So if you look at how this disease progresses and what contributes to the stroke or to the mortality, it's not only the CHADS-S2 score, it's also the concept of the AF burden. So increasingly, we are beginning to understand that AF burden, in addition to the risk factors that predispose to stroke, is an important component of this entire field. In patients who've undergone ablation or in patients who have had heart failure, a low ejection fraction, recurrent episodes of atrial fibrillation predispose them to recurrent hospitalizations. And this in turn leads to increasing mortality. If you look at the effect of ablation on clinical endpoints, especially in the two eras where AADs were compared with rate control and then ablation was compared to medications, you can look at randomized data across over the last 15 to 20 years. In patients where AADs were used, you had increasing hospitalizations, which once ablation set in as the way to give you rhythm control, you had a decrease in the same. Mortality again decreased and the risk of stroke decreased. Going on from there, what do we want to say about the benefits of rhythm control, improved symptoms, quality of life, possible mortality benefit, and possibly reduced risk of stroke? The limitations of the famous AFFIRM trial are well known by now. 17% of the patients who were taken into the trial had failed an AAD prior to randomization also. 35% versus 62% were in sinus rhythm at 5 years. 14.9 versus 37.5% of patients had a crossover, mainly due to the failure of the antiarrhythmic drug or intolerance of the drug. 85% versus 70% were present on anticoagulation. Anticoagulation was not very common in those times. And 70% had dilated left atrial size with LA size greater than 50 millimeters being one of the inclusion criteria within this trial. If you look at the AFFIRM trial 20 years down, we actually are beginning to see that patients who were given rhythm control had higher episodes of heart failure, higher mortality, and higher stroke. Looking at this again, maintenance of sinus rhythm, use of warfarin were the only two things that contributed to improved outcomes, whereas digoxin use and rhythm-controlled DUG use paradoxically actually caused increased mortality. Coming on from there is a newer concept that we have today, arrhythmia-induced cardiomyopathy. Mechanism of AF and LV dysfunction is secondary to the increased RR interval and the variations in the RR interval that we see with atrial fibrillation. Similarly, the absence of the kick, especially in patients with heart failure, predisposes to worsening of outcomes. Again, similarly, in the AFFIRM trial, when we look at patients who had a lowered ejection fraction, these did worse over a longer period of time when they were randomized to rate control. So this is the original tripod that you say that we want atrial fibrillation to be managed with. In today's day and age, I think we have enough data to suggest that rhythm control assumes a larger share with the introduction of my favorite intervention measure, lifestyle measures. What strategy for rhythm control? Now coming to what works when you're saying I want to maintain rhythm, it's not only antiarrhythmic drugs. You need to ablate these patients. Comparison between strategies, catheter ablation does much better than drugs when you're using it for rhythm control. It has a better hazard ratio in terms of preventing further recurrences. In addition to that, recent publications have also shown that compared to patients who've never received an ablation, as compared to patients who have had an ablation, there is a decrease in the progression of disease over time. Evidence on early ablation versus medication. Suppose you took a patient who had atrial fibrillation, decided to give them medications for rhythm control, and had the same patients or similar patients randomized to ablation strategies. You did have this trial, which is almost like a mirror image of the AFFIRM trial, and you actually noted that you had better overall lower hazard risk ratios for mortality. Asymptomatic patients seem to do just as well as symptomatic patients, and clinically, the patients with heart failure did the best of all. Randomizing them to medications as well as ablation showed that patients who underwent an ablation, especially with heart failure, did very, very well. Again, taking the same concept ahead, using the cryoballoon trials that we recently have seen, these patients again had lesser recurrences of atrial fibrillation and better progression or lesser progression to more permanent forms of atrial fibrillation. Remember what we said at the beginning, it is the AF burden that determines whether you get stroke or not, and not only the presence or absence of atrial fibrillation. If you go on in this same line, with the help of the STOP AF trial, there was increasing data to suggest that cryoballoon ablation as an initial therapy was superior to drug therapy for the prevention of atrial arrhythmias and recurrence of the same in symptomatic paroxysmal atrial fibrillation. The same logic is being used in patients with heart failure. In fact, if you look at the Castle HTX trial, patients who were pre-transplant, NYHA class 3, ambulatory class 4, on the transplant list did actually better in terms of getting off the transplant list or not getting an LVAD if they were ablated for atrial fibrillation. This is the famous trial. This come out about a couple of months ago. In fact, the trial had to be stopped at 1 year for the efficacy out endpoints that you notice. The rate of composite all-cause mortality requiring urgent hospitalization, transplantation was much, much lesser in patients who underwent an ablation as compared to the patients who did not undergo the same. Now, does the same logic hold for patients with HFpEF? Yes, initial studies seem to actually indicate that progression of these patients into higher grades of HFpEF was reduced when you ablated these patients. They also got back their exercise capacity, which is what is most important in patients with HFpEF. Now, what is the real world data? Randomized data, as we all know, always has some challenges. So if you look at the Gloria AF phase 2 and phase 3 studies, results from close to 26,000 patients, there was a 50% reduction in the composite outcome of all-cause death, stroke, and major bleeding. Similarly, if you look at a meta-analysis of all these randomized trials, you need to treat 5 patients with ablation instead of antiarrhythmic drugs to prevent 1 recurrence of atrial fibrillation. When you look at the primary composite outcomes for these patients, early initiation of rhythm control therapy was associated with improved effectiveness outcomes in patients who had been recently diagnosed with atrial fibrillation, even within the first year of this diagnosis. So what strategy do we use for rhythm control? Is it cryoballoon or is it radiofrequency ablation? Recent studies seem to suggest that it does decrease. Any form of ablation decreases the progression. You decrease or slow down the progression from patients having paroxysmal atrial fibrillation to more persistent or permanent forms of atrial fibrillation. And with the Circa-Dose study, the 3-year outcomes, it seemed to suggest that radiofrequency ablation did a better job of preventing further progression into more persistent forms of atrial fibrillation. So these are the 2 energy sources that we've always talked about. One of the common complaints we've always heard is, hey, it takes too long in the lab. We really can't afford this. The challenges are that if you don't do it early enough, you'll have a greater challenge later on. And in addition, in the pipeline, pulse field energy with the promise of actually allowing you to be in the lab for just about 60 minutes to complete this entire process surely seems to be a game changer. Going on from there, is it only for patients who present with paroxysmal atrial fibrillation, or is it for patients who present with persistent atrial fibrillation? Similarly, early in the course of disease, if you intervene in patients with a persistent atrial fibrillation with ablation at an outcome cost of around 1.2 to 1.5 procedures, you will be able to achieve sinus rhythm in these patients. How do we achieve these outcomes? It is by, in accordance with the guidelines, use of force sensing technology, as well as we have shown, use of intracardiac echoes. Critically, when you look at a 15-year outcome across all the generations of AF ablation, best outcomes were for persistent atrial fibrillation and paroxysmal atrial fibrillation, but these outcomes were only achieved with contact force technology in patients who are younger, in males, in patients who had lesser AF duration, and in patients who had lower CHADS S2 score. So I'm not all about ablating the atrial fibrillation. Sometimes you're not able to ablate the atrial fibrillation itself. Therein comes this pace and ablate strategy, where you ablate the AV node in patients who've had heart failure in the last 1 year, implant them with a resynchronization device, and you have a close to 50% decrease in mortality when you do this, thereby again proving that it is the burden of atrial fibrillation and the RR interval variability that happens in these patients, which is critical for the prevention of mortality and heart failure. The recently evolved guidelines in management of atrial fibrillation, published just about a month ago, suggests that the best patients for rate control are those patients who are older, with a longer history, who have easily controlled heart rates, a larger left atrium, less LV dysfunction. This is my critical point as a take-home message for today's talk, is that patients who have less LV dysfunction may do better with rate control. However, if patient has LV dysfunction, it is, as is seen right here, a class 1 indication to ablate these patients, whereas it's a class 2A indication for these patients to undergo ablation if the LV function is preserved. It's not all about ablation, just as it's not all about doing a procedure anywhere. The optimal outcomes are achieved at the cost of actually implementing lifestyle measures, where obstructive sleep apnea management, bariatric surgery / weight loss clinics, as well as achieving a significant management of comorbidities is very important. Nurse-led, physician assistant managed AF clinics need to come up to achieve these outcomes in our own scenarios. What we know right now is AF reduces recurrence of AF, improves quality of life. Foundational approach of that is the pulmonary vein isolation. Radiofrequency ablation and cryo have similar efficacy, but paroxysmal AF always does better than persistent AF, and there is evidence to suggest that progression of the disease can be hindered. What is unknown is, once you've done the pulmonary vein isolation, what else is there to be done? How do we manage these patients better? What are the clinical outcomes when patients have atrial fibrillation with and without heart failure? You can always criticize me by saying, Deepak, you're not talking about the substrate. That's possibly material for another lecture by itself. Amyloid versus non-amyloid, that's something we haven't discussed. What about HFpEF? Are the clinical trials recruiting patients with low risk of progression? What is the role of ILR and what is the cost effectiveness? I'd like to just say we are just beginning at the tip of the iceberg for the atrial fibrillation epidemic that we have. Once we start managing these patients more effectively and with a commitment to rhythm control, we shall see more better outcomes, and our understanding of this disease in our setup shall improve. Thank you for your patient listening. Do let me know if there are any questions.
Thank you, Deepak, for a quick and comprehensive coverage of that. I think we all agree, at least as an Indian cardiologist, we have always known rhythm is better than the rate control, though there have been lots of guidelines coming in last 3 or 4 years, right from our CAFE trial, which was done. Only thing is, as we know, we didn't have a good drugs to control the rhythm. And even today, only lacking thing is a good ablators to do a great job and an improvement in the technology. Of course, that's been happening. Thank you. The floor is open for any questions. Yeah.
What do you mean by ablation? Can you kindly tell me what you mean by
ablation of atrial fibrillation? Essentially means you isolate the pulmonary veins in the left atrium. If possible, in persistent forms of atrial fibrillation, you isolate the posterior wall electrically. You may or may not want to add on isolation of the superior vena cava as well as the cavotricuspid isthmus. These are potential sites for triggers of atrial fibrillation. The entire posterior wall and the pulmonary veins are not part of the left atrium primordia. They are actually part of the lung buds. They fuse together to create the left atrium embryologically. The lung buds which come from the lungs are very, very electrically active. So they form the triggers to start atrial fibrillation. So when I say ablation for atrial fibrillation, it essentially means pulmonary vein isolation with the use of either radiofrequency technology, cryotechnology, or the new baby on the block, pulse field ablation technology. And then you institute lifestyle measures and anticoagulation based on the risk for stroke. You don't really try to cut it out. You basically use radiofrequency energy to percutaneously electrically isolate these structures from the rest of the atria. Thank you, sir.
Thank you.
So please wait. I'd like to request the panelists to give a token of appreciation to Dr. Deepak. Next will be the last talk of the day. I invite on stage Dr. Bharat Raj Karmadikar, Consultant Invasive Electrophysiology, Sri Jayadeva Institute of Cardiac Sciences.
At the outset, I would like to thank Dr. Deepak Krishnamurthy for inviting me for this symposium. So without wasting much time, I'll be proceeding to cardiac conduction system pacing. So this X-ray might be familiar to most of you. So you have a dual chamber pacemaker with an atrial lead in the appendage and a ventricular lead, probably in the apical septum. So 20 years back, this was perhaps the only pacing strategy which was available. However, now we know that there are a lot of limitations with right ventricular pacing, and we are moving towards more and more physiological pacing. So we know that patients who undergo conventional RV pacing, they tend to develop left ventricular dysfunction owing to desynchronous left ventricular activation. And the incidence or the prevalence of pacing-induced cardiomyopathy is to the tune of 10 to 20% over 5 years. So this is one study which shows that whenever you do a RV pacing and you get a paced QRS duration of more than 150 milliseconds, then it is highly probable that patient is likely to develop pacing-induced cardiomyopathy on follow-up. So it is essential that you monitor the patient regularly with echocardiogram to see the LV function. So besides RV pacing, we have got biventricular pacing for patients with left ventricular dysfunction. Yes, biventricular pacing gives you a narrower QRS compared to RV pacing alone. However, there are certain limitations, and the left ventricular activation is non-physiologic because the LV lead is generally positioned in the tributary of the coronary sinus, which is epicardial in location. So the physiological activation is from endocardium to epicardium. However, with CRT, we have epicardium, there is a reverse activation. There is epicardium to endocardium. And in initial few days of CRT, it is always possible that patients develop life-threatening ventricular arrhythmias, polymorphic VTs, because of dispersion of ventricular repolarization. Other limitations include phrenic nerve stimulation, presence of a scar in the lateral wall because of old infarction. You'll not be able to get good parameters, and many of the times you'll have to accept high thresholds in such situations. So why should we consider conduction system pacing? Because nature has made His-Purkinje system as the most efficient way to activate the ventricles. And you can achieve both atrioventricular as well as interventricular synchrony with conduction system pacing. And this has been clearly proven to reduce heart failure hospitalization, reduction in AF episodes, and also improvement in quality of life. So this was the pioneering study by Deshmukh et al., who for the first time showed that conduction system pacing using a conventional pacemaker was quite feasible. However, the success rates were not very high. Still, the proof of concept was there. Then this is the paper from the Chinese group where they showed that left bundle pacing is also feasible, something which was considered improbable because reaching the left bundle, which is in the left ventricle, through a lead from the right ventricle by penetrating the interventricular septum, this was sort of a radical idea. And then now, when we say conduction system pacing, most of the times we'll be performing left bundle branch pacing rather than his bundle pacing. So this cartoon shows the cardiac conduction system. So you can pace the proximal his bundle from the atrial side of the tricuspid valve, or you can pace the distal his bundle. If you go 1 or 2 centimeters further apically, then in the basal ventricular septum, you reach the left bundle pace, left bundle branch. So comparison between the two modalities, obviously his bundle pacing gives you the narrowest QRS. However, there are many challenges in performing his bundle pacing. The lead dislodgement rates are higher. The pacing parameters, thresholds, as well as the sensing of the intrinsic ventricular signal. So it is all compromised with his bundle pacing. That is why we have moved on to left bundle branch pacing. You get a very narrow QRS, and the long-term stability in pacing parameters are excellent. So again, the reason why left bundle pacing is relatively easier is that you have a wide area of target because the left bundle branch is wider when compared to a his bundle. His bundle is more like a cord-like structure. Left bundle is more wider, it's broader. So you've got a relatively larger area to target. And in case you are not able to reach the left bundle, you can always capture the distal fascicles or one of the distal Purkinje fascicles, and then you always get, you generally get a very narrow QRS. So coming to the hardwares, so you've got a dedicated lead, the 3830 lead, which is a 4 French lead, and it is a lumenless lead. So initially it was developed for pediatric pacing interventions. However, it has been utilized for conduction system pacing as of now. And then there is a distal screw here. So there's a distal screw, which is an active screw. And then it is a non-retractile screw. It is always protruding outside. And then you've got a distal electrode, that is the cathode. And then you've got the anodal ring. So the distance from the screw to the proximal ring is approximately 11 millimeters. And this is the sheath which we use to reach the basal septum. So this is called the C315 His sheath. And you can see that there are 2 curves here. So one is to enter the ventricle, and then there is another curve, distal curve, to reach the ventricular septum. So there is one more sheath, which is a deflectable sheath. It is quite useful in patients with dilated hearts. When you're not able to reach the basal septum, you can always use the deflection to reach the desired area of interest. So these are the differences. So coming to the technical part of conduction system pacing. So the initial steps are same like a conventional pacing. However, once you have taken the axis, the next step is to locate the basal septum, basal and the mid part of the septum, where you think that where the left bundle branch usually is situated. And then next step is to screw the lead across the septum to the left side of the septum. So this is little challenging, and initial few cases you may find it difficult. However, once you overcome that learning curve, it is quite straightforward. So once we have screwed the lead, the next step is to check the parameters in the unipolar configuration. So we have to find out whether the tip has reached the left side of the septum or it is still inside the septum. So you check the parameters in unipolar configuration. If the parameters are suboptimal, then you can always screw it further, ensure that you get a good parameter, which I'll be describing later. So as we know that the His bundle is located at the septal aspect of the tricuspid valve. So as electrophysiologists, we generally use a quadripolar catheter to locate the His, and then we go distally 1 to 2 centimeters distally and slightly lower to locate the probable location of the left bundle. So again, this is the conduction system superimposed on a fluoroscopic image in the RAO configuration. So you can see so this is the His bundle, and then distally if you go, you get the left bundle. So without a pacing catheter, you can get a rough idea of the conduction system by looking at the epicardial fat pad and also the contraction ring. So in the systolic frame, you can see that the target area is the basal septum, basal and the mid part of the septum. This is the site which you should target with your sheath, and then you pace initially from this side, ensure that you get good QRS configuration, although it will be wider here, and then you have to screw it little deeper. So this is how you screw the lead using both the hands. It is screwed manually. You don't use a tool to screw the lead. Manually, you have to screw it. So you have to look at certain things, especially lead V1 is very important. You want to get a distal, you want to get a R wave in the distal part of the QRS, which suggests that there is right bundle branch configuration or right bundle branch delay. And then there should be lead 2 and 3 discordance. So 2 should be upright and 3 should be negative. And there should be AVR and AVL discordance. So we know this because of pace mapping. We know that this is the configuration which we get when you pace from the peri left bundle branch area. So once you get an impedance of close to 500 to 700 milliseconds, that is when you stop screwing the lead deeper. You should get a QR configuration. So you can see here. So once you have a Q and then a good R wave in V1, that is when you stop screwing further. If you screw further, then the lead is going to perforate into the LV cavity. And preferably, you should get a positive concordance. So V1 to V6, if you get positive QRS, that means you have captured the basal ventricular myocardium. And of course, as I said, lead 2 and 3 discordance, and then AVR, AVL discordance should be there. And then you can see here, your pacing here. So this is the onset of pacing, and then there is a good isoelectric interval. So if you have done a selective conduction system pacing, you'll get this nice isoelectric interval. So once you have screwed and once you've got a good parameters, you can always check by giving some contrast through the sheath. So this is the septogram, and determine the depth of the lead inside the septum. Also, you can, if there is a perforation through the septum, you can always make out contrast leaking into the left ventricle, and that is when you have to reposition the lead. Finally, you have to split the sheath. Again, people, the cardiologists who perform CRT on a regular basis will be familiar with the technique of slitting. Might be difficult in the initial few cases. However, with practice, this is a straightforward way of slitting the sheath, and then it is not technically very challenging. So as I said, to say that patient has a successful left bundle branch capture, you have to fulfill certain criteria. You should have a QR pattern, that is RBB pattern in V1. There should be lead 2 and 3 discordance and AVR AVL discordance. And finally, you should have a short R wave peak time or the LV activation time. That is the time from the onset of pacing, that is the stimulation artifact to the peak of the R wave in V5 or V6. So preferably it should be less than 75 milliseconds, which means you have captured the conduction system. And before pacing, if you get a left bundle branch potential, then that is an excellent sign that you're in the region of the left bundle. So again, this is important. So in the first slide, in the first panel, you can see the patient with left bundle branch block. Then you got conventional pacing. Then you got selective his bundle pacing here. And finally, this thing is left bundle. So the difference is that you get prominent R wave in V1 with left bundle branch pacing. So these are some of the studies which showed that left bundle branch pacing is safe and effective with almost negligible long-term complications such as lead dislodgement. So I'll show a few cases. So this one patient with non-ischemic cardiomyopathy. So patients with non-ischemic dilated cardiomyopathies, especially if they don't have any septal scar. So these are the classic patients for left bundle branch pacing. These patients also do with biventricular CRT. However, the advantage of conduction system pacing in this scenario is that you can accomplish the same thing with a dual chamber pacemaker. So it is significantly less expensive when compared to biventricular pacing. So this is the final ECG. You can see a very narrow QRS. So this is the 12-lead ECG. One more case who had undergone a biventricular CRT almost 8 years back, and then who presented with end of service of the CRT, and then he presented with heart failure. So CRT was not working in this patient. Patient was a CRT non-responder. So the EF continued to decline despite biventricular CRT. So you can see that the EF at presentation 8 years back was 30%. It continued to decline despite biventricular CRT, and the lead position is acceptable. It's a standard tributary. And then this patient underwent left bundle branch upgradation. And then I'll just show you the final. So this was the final QRS. You can see that it's very narrow. And then immediately within a few months, there was a significant improvement in ejection fraction. Finally, the last case. So this was a patient with bicuspid aortic valve who had underwent a aortic valve replacement, then presented with pacemaker infection, and then we had to do it from the right side. So this patient had significant left ventricular hypertrophy. So we know that patients with aortic valve disease, they are prone for AV blocks. So whether it is surgical AVR or whether it is transvenous, that is TAVR. So conduction system is an excellent modality in these patients. And this is my final slide. You can see here. So you have conventional pacing and conduction system pacing superimposed. So this is a temporary pacemaker. The QRS is wider, whereas with conduction system pacing, you got a very narrow QRS. So to conclude, left bundle branch pacing is safe and effective. You don't have to be an electrophysiologist to do it. Even a interventional cardiologist can do it with sufficient interest. And although there is an initial learning curve, but still it can be mastered. Conduction system pacing restores physiological left ventricular activation, and it gives you stable long-term pacing parameters. Definitely, it is superior to conventional RV pacing. It is alternative to biventricular pacing in patients with heart failure and left bundle branch block. Conduction system pacing is less expensive when you compare with conventional CRT. And certain limitations include patients with ischemic cardiomyopathy, patients with old antervolemi, and patients with infiltrative cardiomyopathies who tend to have septal scars and who also have diffuse conduction system disease. So these are not the great candidates for conduction system pacing. Although you can always try conduction system pacing, and if it fails, you can always implant a LV lead in these patients. So this approach is called as left bundle branch optimized cardiac resynchronization therapy. So I'll stop here. Thank you for the patient listening.
Thank you, Bharat, for that very lucid and loaded with lots of clarity on the procedure. Of course, you made it look much more simpler than what it is actually. But as an upcoming modality of therapy, we have also seen its benefit in last few years. Any questions from the house regarding this? There are no questions. Thank you.
Thank you.
I'd request the panelists to give a token of appreciation to the speaker.
Very close to the critical Kauery Hospital,
A very good afternoon, ladies and gentlemen. It has been a very exhilarating experience over the past 2 days, starting from yesterday noon to till now. It has been a very enriching experience for all of us to have heard about the various topics which has gone into 4 sessions since yesterday. And thanks to all the speakers, all the panelists who could made up their mind and be here today. To start with, I sincerely thank our chairman for giving us this idea of starting this event and pushing us to get it done at a short notice. And I think he made us believe that we could do it. Thank you, sir, for giving us the confidence and the trust in us. And from here onwards, this event is going to be an annual feature, and every year it's going to be conducted. Thanks to our executive directors, Dr. Vijay Bhaskaran and Dr. Senthil Kumaran, for having been the pillar of strength for us in shaping up the event for over the month and giving us directions on how to proceed and even finalize the structure of the program. Thanks to our MCs, Dr. Suhas and Dr. Swati, for conducting the event for over the past 2 days and standing over here and absolutely holding on the event. Except that we are probably half an hour delayed. I think we were more or less on time in every topic since yesterday. And thanks to all the speakers who could stick on to their times and we could manage it well. Also thanking our summit coordinators, Dr. Ajit Pillai and Dr. Arvind Kumar, for arranging the speakers and topics on time and giving very relevant subjects. Thanks to our cardiology team of Electronic City and our Marathalli branch and the cardiac surgeons teams for shaping up the event and guiding through us and arranging the topics and the sequence in which the topics have been come out, and it has been widely appreciated by all the audience. Thanks, operations team. Mr. Wilfred Sampson, Vice President, along with him are Deepthi and her team over the past few days running around with all the arrangements of the accommodation, transport, bringing up the speakers, the delegates up to the venue and sending them back safely. Thanks to the marketing team for arranging a big, huge crowd over here across the two states of Karnataka and Tamil Nadu. The branding team, Mr. Digvijay and team of both ECB and Maratali for giving us very stunning visuals of the entire event from static boards to all the digital boards, what has gone through. Thanks to our sponsors, especially Boston Scientific, Merrill and Medtronic for arranging the international speakers and also the Mankind Pharma, Abbott, Amaryllis, Bapuji Surgicals, Perimo, and Translumina for sponsoring the event. The audiovisual team over here, our transport coordinators who arrange for all the transport. Last but not the least, you, the audience, for being with us for all the 2 days, continuously going through the sessions. And we thank you immensely. And we will meet soon in a year's time. Thank you so much. So let us join for lunch. The lunch is being organized at the ballroom on the inner side of the hotel. And one small request for those of the delegates holding the rooms, request you to kindly check out. We got a notification from the hotel authorities. So kindly check out and leave your baggage in the reception hall for while you await for your taxis. Thank you once again. Jai Hind. The Kauery team can assemble on the stage for a group picture. Both doctors and the operations marketing team. Quick, please.